करोनाला विसरा.
आहे कुठे?
We are live now.
Great. So thank you, Bhavik. I welcome everybody to the second day's morning session of eMAPCON 2020. After a very successful Saturday evening, we are on to Sunday morning now. And on the outset, I would wish this robust audience a very happy Dasara. I wish your entire family enjoys Vijayadashmi by achieving Vijay over the coronavirus. And we all come out of this as safe and sound as we should be. And I hope to shake hands with everybody here on a physical conference in the year 2021. So please take care of each other. Please take care of your family as well. We hope to meet soon. Having said that, a few pointers for the chairpersons. Please adhere to the time. 15+5. We need to stick to the time, please. For the speakers, as the chairpersons would give you a small little reminder at the 14th minute of 5 minutes remaining, and then at the end of it, a 1 minute reminder also will be given. Chat boxes for all the audience. Please write in your chat your questions onto the chat box. We shall be asking the speakers. The chairperson will be shown the questions. Whoever questions are unanswered, we'll try to get back to them with the proper answer with the concerned faculty on the email to you after the program is over. So having said that, it's 10 o'clock. We start, and I would ask Bhavik to please proceed with the scientific sessions.
So for the first session, we have Dr. Rahul Pandit, who will be talking about COVID-19 ARDS. Let's stick to the basics. For this, I would like to call upon Dr. P.K. Joshi, who's a senior physician from the Pimpri-Chinchwad, Pune area. He's been a faculty in numerous talks, and he's been one of the founding members of MAP. On to you, sir.
Hello, good morning, everybody. As we start the first session, Rahul Pandit is a senior intensivist in charge of ICU at Fortis Hospital, Mulund, and is a member of COVID force in Mumbai. And of course, he has meetings with all senior COVID task force in the Mumbai. We have seen him also on TV with the Chief Minister of Maharashtra about talking about COVID and everything. He's going to talk on COVID-19 ARDS. Let's stick to basics. Rahul, floor is yours.
Thank you, sir. I will just get my screen sharing.
Request everybody to else to please turn off their mics and the videos.
Yeah. Till the screen is shared, we know the ARDS is most important complication, particularly in COVID.
Can you see my slides, sir?
We can see.
Yeah, we can see your slides. You can go ahead, please.
Thank you. Good morning, everyone. Very happy Vijayadashmi to all of you. And I sincerely hope that what Dr. Saraf said in the beginning, that I would like to basically have a physical handshake with all of you in the next conference 2021. And we hope that this corona goes away with the auspicious occasion of the Shera coming up today. I'm going to talk about ARDS, and basically I'm going to say that the gist of the talk is that let's stick to the basics. Let's not try anything magical. Let's not try anything which has basically not been proven. And if you stick to the basics, I think the outcomes in this COVID-19 ARDS are pretty good. Now, going back to the Berlin definition, which came across in 2012, where 2012-2013, where they redefined the way we actually look at ARDS. The old definition got sort of modified, and then we came up with the three or four variables, which was timing, which had to be within the first week, imaging, the origin of the edema had to be excluded, that it is not an hydrostatic edema, using echocardiography, and then based on the PF ratio, you basically have mild, moderate, or severe. Now, why am I putting this? I think the reason I'm putting this is that COVID ARDS, we still need to basically stick on to this definition of mild, moderate, and severe. And you would see that the timing of the insult is pretty much obvious in most of the cases who come to us. And respiratory failure is definitely not explained by cardiac failure or fluid overload. It is basically something which is quite predominantly hypoxemic secondary to COVID. Now, there are three pathophysiological mechanisms with which hypoxemia comes into COVID. The first is the hypoxemic respiratory failure, which actually happens because of the cytopathic effect of the virus on the lung parenchyma itself, which then decreases the surfactant, causes atelectasis, causes club pleural pneumonia, and this club pleural pneumonia then reflects down to hypoxemia, and then we are able to define that as mild, moderate, or severe. On a CT scan or X-ray, these look like ground glass opacities, which are more peripheral than central. And we can see that sometimes they actually increase quite quickly within a span of day or two. And you wonder, why is that mechanism happening? And that's because of this COVID-19 mechanism, which I'll come up very shortly. Now, based on these two things, Gattoni described two phenotypes. This has been debated and this has been basically challenged as well. But I think people need to know this. There are two components of patients which come to us. One is the low elastance. Low elastance means the compliance is nearly normal, and the lung is basically not heavy. The lung is full of gas, and it is completely normal to ventilate these patients. And when you put them on a ventilator, you would see that the airway pressures are pretty much good, but hypoxemia is profound. And then there is this H type, which is the high elastance, where the compliance is extremely poor. And this poor compliance essentially reminds us of the classic ARDS, which we see, where the lung is heavy, full of edema fluid, a lot of pneumonic patches. And importantly, when you put them on a ventilator, the peak airway pressures are very high. These cases are very difficult to ventilate. They may have oxygenation as well as carbon dioxide clearance problem. And these people basically behave quite closely to the classic ARDS, which we know. Now, fortunately, I think the division is 65-35, as most of the studies are saying. So most patients are having a good compliance, L phenotype, where the 35% of the patients have a H phenotype. There's also a discussion about L phenotype progressing eventually to H phenotype in all of these patients if you don't treat them well. So I think timing is important. If you really believe in this theory, you need to catch them when the compliance is good and not let them go to the point where the compliance becomes a problem. The second mechanism with which we see these GGOs coming up very fast is this cytokine or the immune phase, which is basically because of a dysregulated and excessive immune response. Now, the neutrophils and the monocytes in the lungs and in the other cells produce profound amount of pro-inflammatory markers, especially the TNF-alpha and the IL-6, which have been the two big culprits which we know of. And these are the ones which actually cause this pneumonia to go from being mild to what the CT scans now describe as CORAD 20, 21, 23, whatever it is. But I sincerely feel that the CORAD scoring is not really correlative of the clinical scoring. So I think we need to sort of have the clinical picture as the main point of assessing these patients, and then, of course, relate it with the CT scan finding. The third and the important mechanism, which is often debated again, but I think there is some truth to it, is this hypercoagulable state. Hypercoagulable or prothrombotic state, which leads to the small clots formation. And we have seen increased levels of fibrin and fibrinogen in these patients. And we know that these patients may actually have a significant amount of clots, which may then hamper the pulmonary oxygenation further. So based on this, some amount of patients may require ventilator. And we know that ventilating in the ARDS, these are the four principles which we want to avoid: the barotrauma, volutrauma, biotrauma, and the shear forces. And we have to basically adhere to these principles in ARDS with COVID-19 as well, because any of these happening are only going to basically declare a worse outcome for our patient. So what do we do? Is there a evidence? Well, one of the first evidence is that you only need to supplement oxygen if the saturation is less than 93. So you need to have a restrictive oxygenation strategy. You don't need saturation of 99% all the time. God has given only 21% oxygen for us to breathe. Most of us breathe on that oxygen and saturate around 100%, 98%, 99%. But when you are ill, you don't need to have a saturation which is normal, but you need to have saturation which is adequate amount to provide your nourishment to the cells. And that is easily achievable with a saturation of around 93 to 95%, 96%. So keep the sats between 93 and 96. And if they remain hypoxemic, then the second thing which has worked in this pandemic, which again is an extrapolation from ventilated patients, is this awake proning strategy. Now, we have been awake proning patients even before they require oxygen. And trust me, many of these patients actually do quite well even before they require oxygen. And this strategy should be that they should spend at least 12 to 14 hours in a day in prone position. Even patients whom I manage on teleconsult at home or what we call as home quarantine, we advise them to sleep prone as much as they can whenever they are sleeping. Obviously, they don't need to sleep in the bed all the time, but whenever they are sleeping, try and sleep prone. The second equipment which has suddenly come to the light is this high flow nasal cannula or the high flow nasal oxygen. Now, there was this Florali trial which was published a few years ago, which looked at HFNC's role in moderate to severe ARDS. And there is some benefit of using this technology, which is not new. I have been using this for last 15 years, at least in Australia, whenever I go. But certainly in India, in the last year or so, this has picked up, and the pandemic has certainly given a lot of boost to this. The only problem with this technology is that it uses large amount of oxygen. The small nursing homes need to be very, very wary. See, if you put up a patient on 40 liters per minute of flow, and your FiO2 is 50%, that means 20 liters per minute oxygen is being consumed by a patient. That means around 1200 ml of 1200 liters of oxygen will be consumed in an hour. That means a jumbo cylinder would only last around 6 to 8 hours for that person. So just remember, people who have oxygen tanks or liquid oxygen tanks can certainly use it, but small nursing homes need to keep an eye on the oxygen. Now, this is the study which has been given for publication right now. I've got some data from Fortis. This is my own data. We had 260 patients, of which we have PF ratio less than greater than 200, which is sort of mild patients, and less than 200, which is moderate patients. And you could see that we had around 107 of them on ventilator, 107 of them on HFNC, 46 on ventilator. And in the mild ones, we only had 3 on ventilator and 12 on HFNC. And we had extremely good results. We had 89 of those patients do extremely well, and around 18 of them still required to go on a ventilator. And I've got some ventilator data coming up as well shortly, which I will show. And in both of them, I had an increase. I have a settling down of the respiratory rate, and I have an increase in the PF ratio when HFNC was used. So I think HFNC is a technology, if it's used properly, basically does quite a good thing for you. Now, what about mechanical ventilation? This is a study which was published yesterday in Lancet. It's an observational trial publishing, basically looking at around 550 odd patients who went on a ventilator with COVID-19 pneumonia. And essentially 530 patients completed a 28-day observation period. And all of them adhered to the principle of ARDS trial. So all of them had a mean predicted value of tidal volume of around 6 ml per kilo. You can see it's around 6.5 here. The mean PEEP was somewhere around 13. And you can see the driving pressure. Driving pressure is the difference between a peak airway pressure and the mean, was less than 15. And your compliance was somewhere between 30 and 40 mils, 40 mils per centimeter of water. So they stuck to this basic principle. And the previous mortality, which was being described as 35 or as 50%, 70% on ventilator, they observed that the mortality was around 35% on these patients. So if you stick to the basics, I think it's the largest trial published just yesterday in Lancet, and it is not a trial, of course, an observation study. I think it tells us a lot. If you stick to the basics, the outcomes are not that bad. Now, what do? We know this, that ARDSNet trial basically has got 2 or 3 components which are important. So this was the 2000 NEGM study, which looked at 6 versus 12 mils and found out that 6 mils of per kilo of predicted body weight actually had a fantastic outcome as opposed to the traditional 10 to 12 mils per kilo body weight. This was stopped in the 4th interim analysis because of clear efficacy seen in the low tidal volume group. Second is the prone position. We use prone position extensively as soon as the patient is intubated for hypoxemia and ARDS in COVID-19. We prone them. And what does proning do? Proning brings the ventral to the dorsal, and it essentially helps you in increasing your FRC. Blood flow gets redistributed. There are changes in the diaphragmatic motion, and essentially the secretion removal helps. So around 2 or 3 sessions of 16 hours of proning each actually helps us into improving the outcome of these patients. Where does this data come from? This data comes from the 2014 PROSEVA trial, where around 230 patients were recruited in supine versus prone group, and an average 17 hours of prone was given. And the prone patients had got clear benefit in terms of survival. The single most important thing which they did differently in these patients was prone. Everything else was quite standardized for the 2 groups. So I think prone is a must. The other thing which many a times we don't do and we don't stick to the basics is actually for the first 48 hours, give these patients good sedation and paralysis. Especially if you're going to prone them, we actually put them on a continuous infusion of neuromuscular blockade. There have been recent 2 or 3 studies which have challenged this concept, but I think if you're going to prone them, there is no way you're going to get away without actually sedating them and paralyzing them completely. However, I think this needs to be basically practiced up to 48 to 72 hours. If it goes beyond that, then you are going to be in trouble. The third strategy was basically high versus low PEEP. Now, there was no consensus And hence this trial was, the ARDS-NET trial was stopped because of futility in the second interim analysis. And what most of us do is we go as per the FiO2 and PEEP chart, which is present on this same trial, which gave us the FiO2 PEEP chart, and we sort of go with a PEEP of somewhere between 8 to 14 is the PEEP requirement. So no significant differences. I will just skip on this slide. This is the last slide which I have, and I hope I'm sticking to the time limit, Dr. Joshi. This is my data. So my data is basically, this is data around 3 months ago. I've given this for publication, accepted now. 70 patients who were put on ventilator out of 266. We managed to extubate 35 patients. We had 32 patients who, 32% of the patients who went percutaneous tracheostomy. And our mortality in ventilated patient group is 25%. So we actually had a better mortality than the trial just published 2 days ago, yesterday, 25%. And our overall ICU mortality for patients who are moderate to severely sick is around 10%, 9.92 to be precise. So I think if you stick to the basics, we actually will get good results with these patients. What we are doing is we are floundering these patients on high FiO2s with high flow nasal mask or with BiPAP or with CPAP, and they're spending 100% of oxygen on days together. And then when they crash, we intubate them. And that's when we actually lose them, because you've lost precious time from them to be converted from a low and a good elastance to basically go for a poor elastance and a poor compliance. And that's when these patients don't do well. So my submission would be, don't hesitate to ventilate. Stick to the basics. You have your ARDS-NET trial, which has been proven and shown us in the last 2 decades that it actually works. Outcomes are better with ventilator. Don't hesitate to use ventilator. Prone the patients, sedate and paralyze them in the first 48 hours, and you would have good outcomes. Thank you very much. Yeah, I have stuck on to 15 minutes exactly, sir.
Exactly. Very thank you, Dr. Rahul Pandit, for an excellent presentation. And it was absolutely practical tips what you have given, that we have to stick to the basics. And because we have 2 types of high heavy lungs and the light lungs, and the compliance also. And very important, sticking to basics is again endorsed by the yesterday's Lancet published trial of 530 patients. Sticking to basics, the mortality is around 35%. It is nice to see that you have got a mortality less. So we will go to the questions.
So presently none in the chat box. Presently there have been no questions in the chat box. Sir.
Yeah,
excellent.
In the chat box, yes.
I think sir was so impressive in his talk that nobody asked questions.
So his teaching is so good that even everybody will understand what exactly basic things you have to do. It is like the lecture was like a bedside teaching to the person. Very nice, sir. Very good lecture.
Sir, before intubating, sir, can I ask one question?
Absolutely.
Yes, sir. Before intubating the patient, suppose we do have HFNO, so how the results are better? Are the results better with HFNO than ventilation as such?
So, sir, the policy which we have stuck to, and we consistently follow that without any breach, is that once the PF ratio goes below 150 on HFNO, we start thinking of ventilation. And we basically do everything over the next 2 to 4 hours to try and improve the ventilation as much as we can on HFNO. So that means we ask the patient to lie down prone, we may give some furosemide to try and dry out the fluid, we may give some physiotherapy and see if that improves. If for the next couple of hours it doesn't improve, we repeat a EBG. And if it is still below 150, we go ahead and ventilate the patient electively. We don't wait for them to...
Yeah, correct. We should not to crash. There should not be a crash.
We don't even wait for them to have increased work of breathing to the point that they would get fatigue. So mild increased work of breathing, HFNO, PF ratio below 150, intubate.
That time they are in the lighter category. Definitely the lungs are the L-type.
And they're L-type lungs. Yeah. So since this trial which I showed you, I have ventilated now another 140 patients. So I've got a data of 210 patients now. Obviously, this was the early publication which I have given. The whole publication will come up. But the outcomes are still the same.
Yeah, but about the L-type lungs, how is the outcome and how is the...
Very, very good. We are able to extubate all L-type lungs, most of them.
And the
others require tracheostomy. And if those patients die, they don't die of hypoxia, sir. They die of secondary sepsis. That is the problem. Right. So they die of some infection or something.
So the lungs are light. That time we should be intubated. So the outcomes are, that's the message definitely. And we will not wait longer on HFNO or other methods till patient crashes or his lungs become very heavy.
Correct.
That's a very good message, sir, you have given.
Sir, can I ask Mangesh here, sir? Can I ask Rahul?
Please.
Rahul, can I ask one question?
Absolutely.
Sure,
Yeah,
sure.
yeah, Rahul. But if you really look at the data which has come up from Italy and the European countries, where they were very overzealous in intubating the patients, the mortality was so high in these people. And then probably the concept of delay intubation as much as possible has started coming up. And now again, probably we are coming back again to, I would say, elective ventilation as quickly as possible, especially invasive ventilation. So what was the actual reason why these people have so much of high mortality in spite of being, very aggressive on the ventilations?
Sir, the thing here which basically made a difference for India is that we actually had an opportunity to learn from the European nations, especially from Italy, Spain, US. So we were in a better position. We knew by the time India got hit badly in April and May, we knew that you ventilate them on time without them worsening to the classic ARDS picture, they will do well. The problem with Italy and Spain was that they were just very new to the disease at that time, and they were using CPAP. Patients were happily hypoxic. They were not really recognizing. Even now, so one of the biggest fear which I have is when I talk about ventilation to these patients, the patient actually speaks with the family on the phone. ठीक है, मैं बड़ा है, I'm okay, and then we are talking about ventilation to the family. So it is actually it is a difficult thing convincing them on the phone that this is the right thing to do. The biggest challenge is to speak with the family before that. Once the family is convinced that this is what we do, and we've now have a reputation that we would actually go ahead and ventilate patients. And even before they come in, I tell them that, look, this is our policy, this is what we do. And we have stuck to the basics. Whatever every doctor has said on this webinars in the last 9 months, he is now saying exactly the opposite today.
Exactly.
We were talking about tocilizumab, we don't use tocilizumab. We were talking about steroids, we are still saying steroids should be used, but the category should be only a hypoxic patient. Remdesivir has made a U-turn now. So, remdesivir is almost like the poor drug is almost like the drug is in search of a disease. वही तो disease होगा कि मैं काम कर जाएगा करके.
Dr. Joshi, can you please?
Yeah. So here we
sir,
bolo. Yes.
Can you ask him what was the longest duration they had a patient who was on ventilator survival?
Acha. Yes.
Asking my unit.
Yeah.
Yes.
I ventilated patients for more than 2 months now, and they've got better and gone home.
I think let's give a big clap to Pandit sir. 2 months is a fantastic time, and then post ventilation, rest of the other things are different story. But I think ventilating 2 months and maintaining is just a commendable job. Hats off to you, sir. Hats off to you.
So thank you, everybody. Your time is up now, and I tell the August.
Thank you, sir. And happy Dashera to all of you. I'll take your leave.
Happy Dashera to all.
Thank you.
Bhavik?
Yes, sir.
Yeah.
Yes, sir. So for the next lecture, we have Dr. Mangesh Devaskar. He's going to be talking about COVID-19 and human immunology. I would like to welcome Dr. S.V. Kulkarni, who will be chairing this session. He's a senior physician from Apollo and MGM Hospital, Navi Mumbai. He's the ex-treasurer of MAP, organizing chairperson of MAPCON 2019 at Vashi, and ICP governing council member. On to you, Kulkarni, sir.
Thank you, Bhavik. Thank you, Amit, for this wonderful conference. It is absolutely at a Swiss precision. I bring you greetings from my birthplace, Tulzapur, on this auspicious day of Dasara. We have got a wonderful speaker lined up after Rahul. The real crowd, it is the darling of all the medical crowd. A gold medalist in MD medicine.
Slides दाखवायला सांग रे त्या कंपन्यांचे जरा.
MBBS in biochemistry, pathology, microbiology, and
immunology HBCC slide.
And that he is going to prove that how a simple explanation about basic of pathology and immunology in COVID can make a difference in management of it. He is the General Secretary of National API, ICP, as well as PRF, on the editorial board of so many journals, and he has delivered more than 1,000 lectures, presentations, papers, and posters. So with this brief information about my dear good friend Mangesh, I request him to talk on the immunology of COVID in a very simplified way. Mangesh, please. Mangesh, you are muted. You have to unmute yourself. Please unmute. Bhavik, can you unmute Mangesh?
I'll just try so once.
Yeah.
Yeah,
He's in.
is it okay? Am I audible now?
Yes, please. Please go ahead,
Yeah.
Mangesh.
Yeah. Okay, thank you. Thank you so much. And thank you, Amit. Thank you, Narayan. Thank you, Dr. Mahavarkar, Dr. Rajadhyaksha. And it's been such a pleasure to see you all on the same platform. And thank you, Dr. Pandit, for raising the issues now. He spoke about, the use of remdesivir, primarily tocilizumab and all that. But, we'll still wait and watch because it might be still too early to comment about these drugs. Couple of trials going against does not really rule them out of the kitty. And also, I wish you all a very happy Dasara, and I'll try and stick to my timings as much as possible. And what I'll try and cover today is probably the role of immunology. But immunology is such a vast subject, especially when it comes to the COVID still. So what I'll try and do is this: that I'll try and justify probably the use of these repurposed biological drugs. What are the concepts of biological? And I'll try and talk to you a bit about the monoclonal antibodies whereabout. Now, we all know that we are at invisible war currently, and we are always, not only today's time, but since the time we take our first breath in this world, we are at invisible war. But then we keep on defending ourselves successfully. And a huge thanks to our immune system. And it's an orchestrated response to an offendant, which actually runs this symphonized orchestra of life. Now, we all know that immunity per se serves you by recognizing the insult, by eliminating the insult, thereby protecting you. And of course, it has got a function of healing as well, whatever the damage is inflicted by the offending pathogen or an antigen. Now, this immune response as a result of an insult can be a very rapid and aggressive response, which is usually a non-specific response. It's a generalized response, and it is usually through what we call it as an innate immunity response. Innate, that means innate, you're born with it. This is the immunity, which is usually our rapid acting task force, which generates a generalized, aggressive, non-specific response. And then as the insult persists, we start developing our own cell-mediated and antibody-mediated specific targeted response that governs through what we call it as a cellular immunity or a humoral immunity, or what we also call as an acquired immunity. And there are multiple immune cells and the systems which play a role in this rapid acting team and a slow response team of adaptive immunity. Mostly rapid acting response team has got the macrophages, the granulocytes, the dendritic cells, and the adaptive immunity team, they contain more of lymphocytes, especially B lymphocytes and T lymphocytes. And of course, B lymphocytes generate a lot of antibodies once they get converted after the trigger to plasma cells, which actually give us the antibody production. And T cells and natural killer cells, they work for both innate immunity as well as the adaptive immunity. Now, it's a beautiful fun fact that I want to bring it to notice. Can you tell me how much is the daily white blood cell production that we have every day to give us all the granulocytes, lymphocytes, natural killer cells, dendritic cells, antigen presenting cells? Can you imagine? I'll show you. 370 billion in 24 hours. Now, that robust production of WBCs that we have. So this whole orchestra of such a robust creation, which actually originates from a pleiotropic, homeopoietic, pluripotent stem cell, which gives you a myeloid series and a lymphoid lineage, which actually give us granulocytes and agranular leukocytes. Now, this all they work in tandem in protecting us. But then I always used to wonder, so much of cells, so much of generation of the WBCs and various cells, how do they communicate to each other? How do they know and how do they understand that you are insulted? How do they recognize what is self and what is non-self? And then you'll realize that they communicate and signal to each other by a very intricate signaling system, which is by a chemical signaling system, which is usually governed by cytokines, as we popularly know, as Dr. Rahul was talking about, and chemokines. We know that cytokines are responsible for the movement of the WBCs, towards the insult, and chemokines are like Google Maps. They direct the WBCs at the site of the insult and make them to reach to the site of the insult and then work there as by generating an acute inflammatory response and also by generating the anti-inflammatory response. And this is exactly what happens in COVID situation, where you can have a beautiful orchestrated, symphonized immune response by the different mechanisms. You can clearly see on this picture, which was published last month in the Nature, where you can see that all the cells, all the different chemicals, the signaling systems, antibodies, they work in tandem to take care of an immune response. And it works as a beautiful symphony orchestra. But then in few of the patients, few of the unlucky patients, because of the excessive viral duplication and all other factors, this synchronized symphony starts becoming dysynchronized. And then what happens? It's an absolutely dysregulated, hyper sensitive, overreactive immune system that we have. So this orchestra becomes and gets converted into what we call it as a cytokine storm, leading to all the possible complications and the life-threatening situations. But to label it as just a cytokine storm may not be a correct word. The correct word for this would be a dysregulated inflammatory response that these patients have. And this usually starts in the alveolus, as Dr. Pandit has already talked to you, and an outraged immune blizzard sets in, which leads to ultimately an immune paralysis, leading to not only the local inflammatory serious response, but a generalized systemic inflammatory response, which will ultimately lead to multi-organ system failure and death.
So
Yesterday, Dr. Ashi Tegde also talked about, what are the different immune pathological mechanisms. You have got hyperacute, excessive T cell activation happening. The lymphocytes are dysfunctional. There is a depletion of the lymphocyte response. There are excessive neutrophils and granulocytes which are recruited at the site, which ultimately trigger the production of inflammatory cytokines like interleukin 2, interleukin 6. And there is a inhibited action of the anti-inflammatory cytokines like interleukin 10. And plasma cells, they get triggered, causing excessive production of the non-helpful antibodies. The antibodies, rather than working towards the antigen, antibodies starts generating what we call it as antibody-dependent cell-mediated toxicity or enhancement, which starts killing their cells also. But remember that antibodies cannot kill themselves, per se because of them. Antibodies, they trigger the killing mechanisms. So this storm, which actually is there, can be withered by immunomodulators or immunodampeners, what we say. And that is the place where probably we have got all these repurposed drugs in a form of biologics. Our knowledge about the similar kind of thing happening during the MERS time has given us a chance to explore the possibility of using all these immune modulators or immune dampeners, or what we call it as cytokine inhibitor biologics. So let's talk about biologics very quickly. Popular biologics that are used in immune system and to treat COVID currently are usually monoclonal antibodies. And you all have heard the names of itolizumab, tocilizumab, and all that. So let's have a look on biologics. We need to understand that biologics are the revolution of healthcare today. They are the need of the hour. They are not only the need of the hour now, but they are going to be the need of the generations ahead, because they give you very, very specific and individualized care and target specific approach for the management of the disease. They are used to treat a lot of difficult situations, a lot of difficult diseases like malignancies, neuromuscular disorders, autoimmune disorders, arthritis, and so many other things. And the best part is that these antibodies, which are therapeutic antibodies, can be also utilized to deliver the target specific doses. It may be the drugs, it may be the radiation as well, as it is beneficial in the malignancies. We all know that antibodies are antigen binding proteins, and they are secreted mostly by the plasma cells. Now, plasma cells are beta cells. After trigger or sensitization by the antigen, they get converted into plasma cells and they keep on manufacturing antibodies. Now, these antibodies, they keep on circulating in the blood, where they serve as a trigger or activating the guns of the immune, immune offering cells, or the or the T lymphocytes or the natural killer cells. They arm them and they make them to destroy the offendant or even the cell which has engulfed the offendant. We all know that there are 5 different types of antibodies that we have. Most of the antibodies that we have are usually monomeric, but IgA is dimeric, and IgM, which is a rapid phase respondent, is a polymeric antibody. Now, what is a polymeric or a pentameric? Now, remember that if you really look at the structure of the antibody, a schematic diagram, we know that here that there are different, I would say, chains that you see. The blue chain that you are seeing, they are called as heavy chains. They have amino acid sequences, a huge amino acid sequences, and usually the atomic weight is around more than 1 lakh Daltons. And the light chain has got an atomic weight of around 55,000 Daltons. Now, these chain have 2 different areas. One is a constant zone which cannot change, and the Y-like structure, or the 2 arms of the Y that you are seeing, they are the variable zones which can be changed, which can be engineered, which can be tailored. Now, this Y stuff, is responsible for sensing the antigen, and they hold the antigen, they fix the antigen there. Whereas the constant fragment or the CFC fragment, what we say, it interacts with lymphocytes or the granulocytes and sticks and presents the offending antigen to the natural killer cells or the dendritic cells. So
5
the
minutes left.
antigens that they have there, they have something called as epitopes, which are the antibody sensing the antigens, which are been, that's how the antigens have been sensed by the antibodies. Now these are these epitopes which will be sensed by the antibodies. Antibodies will get attracted, will catch hold of the epitopes. And each epitope that you can see, these different shapes of epitopes here, they have got a specific antibody. So an antibody against this shape epitope is only one. And if one antibody is generated, then they are called as monoclonal. That means they are sensitive to only one sensing to only one type of antigen presenting epitope. Now remember that therapeutic antibodies primarily can be monoclonal, as we already have seen that they are sensitive to only one single type of epitope, or they can be polyclonal. But then you can see here that once the plasma cell gets in contact with an antigen, the plasma cell memorizes that antigen and it can replicate itself and keep on replicating. And it will keep on going producing the cells. And the same thing is utilized for the therapy purposes as a production of the monoclonal antibodies. Now, these monoclonal antibodies are synthesized. Now, you can see here classically IgG, which is mostly the monoclonal antibody which is used, has got a particular epitope which is shaped like this. So this monoclonal antibody is usually harvested in the animal by what is called as an hybridoma technology. I am not going to talk to you about details about this, but that's the way they are in, the same antigen is injected into the rats or the murine species, and then they are fused with myeloma cells. Now, why myeloma cells? Because myeloma cells have got a tendency to replicate and they survive long time, but they don't produce too much of antibodies. Antibodies are produced primarily by the healthy plasma cells. Myeloma cells will only keep on reproducing rapidly. So by fusing a myeloma cell to a normal plasma cell, what happens is this, that their replication process is on and plasma cell keeps on doing antibody production. So that's how that hybridoma, the combined cell, which is plasma cell plus a myeloma cell, it is called as an hybridoma cell. And these cells are ultimately picked up and cultivated. And these two guys, George Kohler and Caesar Milestone, in 1975 initiated this therapy and were given the Nobel Prize. And these
2 minutes left.
Yes, I know that. The biological products that we have are usually, not only from the mice, but they are also from the virus and fungus and the bacteria. And you can fiddle around with the IgG structure, different types of antibodies that we have together. I think these antibiotics and the biologics have changed the entire perspective of the management of COVID probably, and has offered you a different ways of managing. And these antibodies are known by their nomenclatures. I will not go into the details about it, but that's how the tocilizumabs and the infliximabs and different type of nomenclatures which are used, where it can tell you about the naming system, it can tell you about the antibody targets, the antibody source. I know it's a very complicated subject, but with the given time, I can tell you this, that you can just looking at the name of the monoclonal antibody drug, you can find it out whether it is of a mouse origin or a chimeric human origin or a humanized origin or a human antibodies. With this, I will stop here. I wish all of you the best wishes. Thank you very much for your patient listening.
Mangesh, thank you very much. You really made apparently simple topic really informed with enriched facts and the basics of immunology, which are really very important in this era of COVID management. And whatever you have told, it is a paving word towards personalized medicine. Now, I got a simple query for you that can you predict how a person is going to respond in a particular disease to a particular immunomodulator? Do you have any parameters or any criteria for that?
No, it's very difficult to decide about, that particular person, the way it is. There are hardly very few parameters, but there are some indirect indicators that we can have. As we know that we every person cannot be, sent for investigations like IL-6 estimation or IL-2 estimations or different types of cytokine estimations. But then there are indirect representatives which can be easily done in the laboratory. The best indicator for IL-6, which is an indirect indicator, is a CRP. High CRP is secreted in the liver in response to the IL-6. So CRP rises in response to the IL-6 levels, and probably it can be one of the best indicators. And you can always use D-dimers, you can use always serum ferritin levels as the markers for the inflammation in most of the people. And along with the clinical presentation, you need to hit them hard early if at all you need to get the benefits.
Thank you very much, Mangesh. Your flight has arrived in time and left in time. Amit is very happy about timekeeping. I hand over the mic to the organizing team. Thank you.
Thank you, Dr.
Wonderful
Gavaskar,
way.
as lucid as ever. Thank you, Dr. Kulkarni. Bhavik, please.
Yes, sir. So for the next topic, we have Dr. Satish Kadilkar, who will be talking about online neurology consult. For this, I would like to call upon Dr. Mrunalini Kelko. She's certified in diabetes management from University of Newcastle, Australia. Dr. Mrunalini Kelkar has experience of working at Joslin Diabetes Center at New York. One of the finest female physicians in Nashik, she has a dedicated established practice in management of diabetes and its complications since 1986. She has been the organizing secretary of State Conference of RSSDI 2014 and eMAPCON 2017. She has conducted many public awareness programs and has been awarded for social contribution as well. Mrunalini, ma'am, on to you, please.
Good morning. In neurology, meticulous history and thorough detailed examination of the patient is must to come to some conclusion. History taking is possible online. But what about eliciting various signs like reflexes, sensory system, cranial nerves, cerebellar system? So we all are curious to know how can we do it and what are the different challenges we may face while doing all this. To elaborate on this subject, we have stalwart and eminent neurologist, Dr. S.V. Khadilkar with us. Dr. S.V. Khadilkar is professor and head of the Department of Neurology, Bombay Hospital. He is also dean and medical faculty in the same institute. Editor-in-chief and Annals of Indian, and he's a fellow of Royal College of Medicine and fellow of Indian Academy of Neurology. He has 6 books, 43 book chapters, and more than 150 publications to his credit. He's a teacher and examiner for DM Neurology. So with this brief introduction, I'll request Dr. Khadilkar to start his presentation.
Good morning, everyone. And
Morning, sir. Morning. Good morning.
good morning. I'll share my slides.
Video बंदच होता. मी केला होता मोकळा. Okay.
Yeah. Can you see the slides now?
Yes, sir.
Very nice. So good morning, everyone. First of all, let me thank Dr. Mahavarkar, Dr. Rajadhyaksha, Dr. Devgaonkar, Amit, for asking me to be here. And it was very nice to listen to Dr. Mangesh Devaskar, and I learned about immunology from him. So, and it's very nice to see Dr. S.V. Kulkarni, who is a long-term friend of mine. So when Amit said that this is a topic that you can do, I actually was very happy because last many months I have been doing tele consultations in neurology, and I thought I'll tell you a little bit about how it's going for us. So neurology, like the chairperson said, always is about meticulous history, meticulous examination, then trying to derive the site of the lesion and the type of lesion. And it's believed that it's an exercise that takes time and a system. And all my life, I did consultations that primarily were face-to-face. Even though I must say that at the Grant Medical College, when I think they called it HMIS, when a program came in the Grant Medical College, all the district hospitals were joined with that program electronically. And every Saturday, 9 to 10, somebody from the neurology department went to that room where from a district place, patients were shown to us and questions were asked. And then we would ask for a little neurological examination that the doctor would do. So I did have a taste of long distance examination at that time. And we did it for a few years till I think the need for that became less because there were more neurologists everywhere. But patients have been coming to my office for everything, to show the reports, to follow up, for everything. And very frankly, the system of face-to-face consultation was in a way so separate from electronics that if somebody said, I've sent you my reports by email, I would say, oh God, why has he sent by email? Because I do not have my case paper with me now. How am I going to see? So there was a kind of disconnect and a little discomfiture about doing electronics. But come March, I think everything got changed. COVID changed everything. Patients didn't want to go. You didn't want to go. And at the same time, in March of 2020, the government ordinance came that you could do telemedicine. And since I presume that there is no other talk on telemedicine today, is that correct? There's no other talk on telemedicine?
No other talk, sir.
Oh.
I'll just give a couple of things about the government ordinance, which I think all of us who do telemedicine would like to know. I think I must say that I got a little interested in this and I did a short course of telemedicine, which is considered to be a certified course. So I first got to study the ordinance. So some of the things that are important in telecommunication is that the doctor has to put up his degree somewhere. The patient has to know who you are. You have to know who the patient is. So I think it's very important that the patient also puts in his ID. Like the apps that you use, somebody should check who the patient is and somebody should check who the doctor is. Then I think one big issue was the data privacy, because there is so much that comes on the web and then you know that it can be misused. So I think in telemedicine, as compared to face-to-face, data privacy is a big issue and various people are tackling it in various ways. So the government calls a new consultation as a consultation where you haven't seen a patient before, or you are seeing your old patient for a new complaint. A follow-up consultation is up to 6 months for the same complaint. And the third type they call is the RMP to RMP consultation, where one doctor wants to share his views with another doctor. So those are the types of consultations that have been defined for us by the Indian government. Why is it important to know? Because we'll come to that at the end of the talk. So I started doing these consults, and initially I did only 1 or 2 in the day and got very tired. Then I realized that, okay, it's feasible. Then we went on to more and more. And now I'm quite comfortable with doing the consults. Right. But the interesting part is I had never tried it. And once I tried it, I think it's very much feasible. Now, what do you do when you set up an neurological consultation? You encourage a medical or a paramedical individual in the family, if there is someone, to be present. A physiotherapist, a dentist, a doctor. I think they can, if they are there, then it makes that much easier. And believe me, you can do details of examination if you really have someone like this with you. If patient can upload the reports beforehand and you can study them, that's so much better. Like, for example, my work now for the last few years has been seeing people who have already been seen by neurologists in a sort of a second opinion or a third opinion or what have you. So if patients upload their reports and what other doctors have said and what has already been done for them, that's really useful. You get a total hang of the situation and you know what further can you take. What I'm also doing is I'm keeping an audio and video simultaneously going on, or sometimes alternating. So I have my phone also on the same app and my computer on the same app. So generally, I would start with the audio call. And when the patient is explaining his history, I type it in my computer. Then I do a video for examination. People, of course, like videos. So what's the status of neurological telecommunication? Has it been assessed before? It's been assessed for a long time. From 1990 onwards, there are papers to say that comparison of teleconsult and a face-to-face consult is more or less the same, except for a few things like a plantar response. So it's a validated method of examination. It may be new to us. It was certainly new to me, but it's a validated method of examination. Also, let me make this comment that I've been speaking when this lecture came up, I've been speaking to my friends who do telecommunication. And believe me, there are people who are liking it and there are neurologists who are hating it. So I think there is an individual difference. Like one of my very good friends, Dr. Lal Kaka, yesterday evening, I gave him a ring and said, this lecture I'm doing tomorrow, and what do you think? He said, no, for new patient, it's not okay. I cannot understand anything about a new patient. For old patients, Parkinson's disease is that I'm okay. On the other hand, I am getting very comfortable with new patients, old patients, mixture, everything. So I think we are all different. But our patients are the same. They all want a video call. They want to see you, they want to talk to you. So if you start with an audio call, they get very unhappy. So I have learned to tell them, look, I'm going to start with an audio call. I will follow with a video call, but first tell me what's wrong with you, because I find it much more comfortable when I'm on audio and I'm able to type the history straight away. But they want video. The moment you start, they say, oh, doctor, this is not a video consult. Are you only going to be on call? I think Indians like the videos, whatever the reasons. Now, the various departments in the United States have actually put out formulations as to what all can be done about the neurological examination. Before the examination, let me say one thing. Neurological history taking. I have always taught in the medical college that neurological history taking is the most important thing. Examination tells you where is the lesion. History tells you what is the lesion. As I'm doing these consults, I'm realizing that it is really very, very true, because there are 80% of patients in whom by the time I finish the history, I know what it is. And the examination is perfunctory to just match with what I have found. So I think the importance of history, and history can be taken on the phone just as well as you can do it when in person. And I remember a very senior neurologist who used to say that I start writing, the patient starts telling, and I don't put my pen down till I know what it is. So really I have found that examination is important, but it's the history that is important. So cognitive assessment can definitely be given on the video. However, I have found that it takes a long time, and the maximum time I can give for a consult is 30 minutes, in which I can't finish cognitive assessment. So I have designed a PDF which I send to them. They fill it up, they load it again, and then I look at it at another setting in an asynchronous manner. So cognitive assessment, the MMSE and the Montreal battery have been employed and validated for telecommunication. But I give it to the patient and get their responses back and take a look at them again. And again, believe me, patients' relatives enjoy it. They want to be the examiners. They're very, very happy that we asked these questions and our patient said so, and I've written it down. So it creates a beautiful rapport with them, and it also saves me time. Now here I'm going to show you 3 or 4 busy slides, which are basically from the New York Presbyterian School of Medicine. Where
So
they,
5 minutes left.
yes,
Sorry.
where they have charted out what all can be done with the cranial nerves. And as you can see, starting from the 2nd, 3rd, 4th, 6th, 7th, 8th, 9th, 10th, 11th, all cranial nerves can be beautifully examined in this manner. And there are protocols available. Same is true for the coordination. Let me come to the sensory system. In coordination, I do a finger nose finger test and I do a tandem walking. That way patients feel that they are being examined. For sensory system, believe me, I was very skeptical, but sensory examination can be very beautifully done using a cotton, using the patient's finger, using a toothpick or anything that is sharp at home. And yesterday only, one patient beautifully traced the glove and stocking type of hyposthesia on her mother-in-law. So it can be done. Standing with eyes closed, toe up and down. Everything that you do in the room can be done as the long distance. There are only some parts of examination that you cannot do. What are they? Ophthalmoscopy. You can't do that. So if there is a headache, which is new, then you are handicapped because you don't know what the fundus is showing. Now, there are, of course, some long distance measures of ophthalmoscopy, but we can't routinely employ them. A lot of patients have blood pressure machines, so they check, but you have to rely on what they have done. Tendon reflexes and planters are 2 things that you can't do. So these are the limitations of the neurological examination. Next, in a minute, I'll tell you that I'm absolutely enjoyed the RMP to RMP consults. For last few years, I have sort of been very reluctant in not going to other hospital ICUs or other hospitals because it's cumbersome, it takes time, the liftman stops you, the ICU person asks, who are you? So you don't enjoy that. So I stopped going. But here on a video consult, when the RMP is there, I can go inside any ICU, the RMO can show me what the examination is, and I can discuss with the treating neurologist then and there, or the treating physician. So I think RMP to RMP consults is another thing that I think is very, very useful in this telecommunication. What are the constraints? It's not all hunky-dory. Some parts of examination, as I told you, cannot be done. It takes a longer time. If I can see a patient face-to-face in 15 minutes, it takes a longer time, 30 minutes. Connectivity in some parts of India may be very poor, and some patients cannot upload their reports. Some patients' charging models can be cumbersome. And lastly, let me mention prescription restrictions. Like if you have a new patient whom you've never seen, according to today's rules, what you can prescribe to him is nothing but holy water. You can only prescribe him some vitamins and some ointments and creams. So that's ridiculous. So I think that is where the IMA and the consultant associations have to take it up to make them more logical, which I believe the psychiatrists have done. Everybody in the patient world is not gelling with this type of consult because they want to go to the hospital. It's a trip for them. It's a pilgrimage for them. They want to see the God. So these are some of the interesting responses that I've collated. After the consult is finished, आपने अभी मुझे देखा ही कहाँ है? So video doesn't mean anything for this patient. Some patients do not believe that you will be charging for this. After you finish everything, some say, अब consultation कब शुरू होने वाला है? And lastly, I think they all want you to be available on an urgent video, which I find almost impossible. Now, What do I think? What will happen to the telecommunication when the corona recedes, hopefully, and we go back to our hospitals full-fledged? I think for me, it's going to stay. What is it going to stay for? I'm going to see all my patients' reports online. I do not want them to come to me and crowd the room just for the reports. Because now I have my records electronically, I can check what I have asked and I can see what's come. Most of my follow-up patients, which is basically a carry forward of prescription like epilepsy that's doing well, Parkinson's that is doing well, headache that is doing well, I'll call them as teleconsultation. RMP to RMP consults in intensive care units of various places in India, I will keep them going because it's very easy to do for both of them. And sometimes I'll give emergency advice for urgent patients. I think for new patients, like Dr. Lal Kaka said, I tend to agree with him that it will still be better if you see the new patient first as a face-to-face consult, sort out really what you want, and then take him on to the online consult. Lastly, I think all these things that I'm saying I will do is not yet validated in any protocol by myself. So I'll probably in a year or two continue them and validate them. So that's in short how it's going. It's been a beautiful journey. I never thought I will do electronic consults as regularly, but I'm very happy with the way the facilities are. And I think Indians being techie, most of the times, and I work in Bombay, so most of the times I've not had any problem. So I think there are a couple of minutes to spare. So thank you very much. And I'm open to questions.
Thank you very much, sir, for your innovative, practical way. How we can do online consultation for neurology, like giving us tips like paramedic should be around the patient. It is easy to do it. And then the video consultation, we start with audio, but then they require video. Yes. Plus acceptance of the patient that the online consultation means the consultation and you have to pay for it. Yes. So thank you very much. Are there any questions, Amit?
Ma'am, nothing on the chat box from YouTube so far. So, sir, I remember sir explained this so well that even when I was a student of sir, I think most of our questions were solved by just listening to him.
Thank you very much, sir. But I have one question on the legality, sir.
Yes, of course. Yeah.
So, can they draw us in the law of code for giving some?
I think yes. For medical legal purposes, an e-consult is just like a physical consult. So everything that applies to a physical consult applies to the e-consult in the court of law. So I think we have to be careful.
Careful. Thank you very much.
May I just add?
Yes, sir.
Excellent talk.
Dr. Panek, nice to see you.
Yeah. Yes, and excellent talk. I'll tell you my experience with teleconsultation. Like you said, people love to have a video conferencing. And it's not only the patient, her husband, her children, everybody will come on the video conferencing. And it takes hell of a lot of time. So nowadays what I do is, मैं अभी चड्डी बनियान में बैठा हूँ, किधर video conferencing करूँ, so that I can speak to them on phone and finish it off. Otherwise it just goes on and on. So that is my experience here. But probably you need a video consultation because you need to look at the signs and other things. In diabetes, our reports are the main thing. And maybe just talking to the patient helps.
Yes, sir.
Yeah. I think it depends on, for each one it will be different because each one in the whole sphere of medicine is doing different things. So, yeah.
Thank you very much, sir.
Thank you.
I'll request Dr. Amit to take over.
Sure. Thank you, madam. Thank you, sir. As always, a pleasure to listen to you, sir. Bhavik, can you take it forward, please?
Sure.
Hello.
So for the next talk, we have Dr. Siddharth Shah, who will be talking about COVID-19 and diabetes mellitus. For this, I would like to call upon Dr. Nitin Patankar. He's the present president of API Thane, a senior metabolic physician based from Jupiter Hospital. He has numerous publications and research work on reversal of diabetes to his name. Dr. Patankar, on to you, please.
Thank you, Bhavin, so much. And thank you, Amit, to give me this opportunity to introduce Dr. Siddharth Shah. So basically, it doesn't require actually introduction to Dr. Siddharth Shah. He is MD, FICP, FRCP Edinburgh and FSCP, postgraduate teacher in diabetes and medicine, executive chairman of Hypertension Society of India, and consulting physician and diabetologist at Saifi Hospital, SL Raheja Hospital, and Bhatia Hospital. And today, sir, we are very eager to listen to you about your views on the most common condition in India, that is diabetes, and a threatening pandemic, that is COVID-19. So over to you, Dr. Sir.
Good morning.
Good morning, sir.
Happy Dashera Day. Good morning. Good morning, Amit. I can see you.
Morning, sir.
Let me at the outset thank Dr. Mahawakar, Dr. Narayan Degaukar, and especially Dr. Amit for coordinating and for this brightest occasion of Dashera today. My today's topic is COVID and diabetes, and we all know now that we all know that COVID-19 is a pandemic which is progressing on, and we do not know the end today. But COVID-19 and diabetes has a special significance because this diabetes associated with COVID is definitely going to have a major repercussion in the patients and the public at large. Now, the case scenarios that we are finding today in the last 7 months that the COVID-19 has had a leap for this last 7 months is that what we see in our patients. What we find is that the patient, when he gets diabetes, sometimes it tells us, sir, I have never had diabetes. So we have a situation, we have got patients who are newly detected diabetes. Then we have type 2 diabetic patients who are already known, but they have, because of COVID-19, unstable hyperglycemia, COVID-19 and post-COVID-19 phase. Then we have a peculiar situation of type 1 diabetic developing during diabetes, and associated with that also one has to think about type 1 diabetic patients on diabetes and creating a scenario which is very difficult to treat. What we are seeing in COVID-19 patients is hyperglycemia. 70% of patients with diabetes, we all know, have poor glycemic control. This hyperglycemia can be due to non-compliance of medications during the COVID. It may also be aggravated by anxiety and stress induced by COVID-19. And the third important aspect is the lack of exercise. One aspect of hyperglycemia is weight gain. We all know, talk about the obesity, but what is important is the patient. Some of these patients develop weight gain due to various reasons. And the hyperglycemia is related to the angiotensin converting enzyme receptors, which through coronaviruses enter the human cells and destroy the pancreatic cells. That's why we sometimes see acute pancreatic episodes in patients who have coronavirus, and even sometimes some people developing type 1 diabetes due to the pancreatic cell destruction. Does not raise the risk of getting coronavirus. This is what people ask us often, that I am a diabetic, am I going to get coronavirus? The answer is that you will not get coronavirus as in the general population, you may be affected with coronavirus disease if you do not take care of yourself. But those who are infected are at a higher risk of severe disease, complications, and death. The COVID-19 causes defects in T-cell immunity and have baseline high level of cytokines. The comorbid conditions that are associated with diabetes is what we see day in and out with our diabetic patients. One is obesity. Obesity itself is a very important marker of complications in COVID. Coronary heart disease and hypertension is a comorbid which can give rise to various complications. And we have seen patients due to atherosclerosis and diabetes having acute myocardial infarction and other coronary artery diseases. Hypertension is one comorbid condition which we talk about, and the hypertension may be due to various diseases. Acute and chronic kidney disease is associated with diabetes. Infections attacking the pancreas, as I have shown you, causing pancreatitis, is known with diabetics. Pulmonary diabetes is a comorbid condition, and especially lung involvement in coronavirus is very well known and can aggravate the diabetic scenario. Dyslipidemia is known with COVID, and it is better to control the dyslipidemia to prevent complications of diabetes. The COVID itself can have an effect on diabetes due to the cytokine storm, which is associated with greater mortality, especially in diabetic patients. In diabetes, when patients are given corticosteroids, especially in patients, grade 3 types of COVID-19 complications, especially patients who are on ventilators, where corticosteroids are used. Some people use corticosteroids on day 1, but which is very wrong. And hence, especially in patients with diabetes, this high dose of corticosteroids can give rise to hyperglycemia and other complications. Ketoacidosis is a very severe complication of diabetes and should be controlled with close monitoring and care of ketoacidosis in ICU. A hyperosmolar state has been demonstrated in COVID patients along with diabetes. It may be due to inability to monitor glucose because of reduced contact between healthcare workers and diabetes. That's why monitoring sometimes is not possible, but it is patients who have hyperglycemia and associated complications of diabetes. Close monitoring is the advice that is required for patients who have COVID-19 who are admitted in ICU or even at home. Close monitoring of glucose is very essential in diabetic patients, and documentation of the glucose, day-to-day documentation to control various medications of diabetes for patients who are suffering from COVID-19. Let us look at the medications which have been given to diabetic patients as the effect. Chloroquine and hydroxychloroquine was initially given as a preventive measures. Also, some medical community have used this drug every week to prevent them from getting COVID-19. But now it has been said that this is not required because it causes more complications, cardiac complications, and hence this drug is almost given up. But what is important to remember is that hydroxychloroquine can give rise to lower blood sugars, and people who are using this drug has to be careful in a diabetic patient because his blood sugar will drop and his medications has to be adjusted. Remdesivir, favipiravir, glucocorticoids are all being given in diabetic patients. Remdesivir has come into disrepute due to adverse reports. Favipiravir is being preferred now, but we'll have to see in the test of time to see whether this drug remains, because all these drugs have serious side effects, especially in the liver, and hence one has to be very careful in monitoring these patients, especially the diabetic patients, because of various side effects that persons will have hyperglycemia and the patient will have to be controlled. As we have discussed earlier, glucocorticoids, one has to be very careful because we give high doses of glucocorticoids and the patient's blood sugar will go haywire, and one has to be very careful monitoring these patients and controlling their blood sugar. The antiretroviral drugs, lopinavir and ritonavir combinations have been tried, but has not been proved useful. Even there has been controversy recently because it does not reduce the mortality in patients given human convalescent plasma, especially when you give it very late. Monoclonal antibodies, Trump has been given this, so it has come into forefront, but we'll have to see in future monoclonal antibodies will work. Vaccines, we are looking forward to within 3 to 6 months, but let us see what vaccine effect on the diabetic patients. We'll have to see when we start using these drugs.
So 5 minutes left, please.
Anti-diabetic medicines and COVID-19 medications, metformin, especially in crisis where ketoacidosis is not recommended. DPP-4 inhibitors is routinely used for control of blood sugar in diabetic patients. And SGLT2 inhibitors you have to be very careful, especially patients getting dehydrated. GLP receptor agonists not used very routinely. Sulfonylureas, one has to be careful, causing severe hypoglycemia. Glitazone, I think Dr. Panikar is going to talk on this. Insulin definitely is the drug of choice where it has very few side effects, but when you use other drugs, you have to be careful to prevent hypoglycemia. And what is important is monitoring these patients, especially for the fluctuations of blood sugar. This is the latest September table where they have discussed the various anti-diabetic drug treatment during COVID-19, where all the drugs which have alluded to earlier have been stabilized, and the disadvantages have already been shown over here. SGLT2 inhibitors, risk of hypoglycemia, electrolyte imbalance, and euglycemic ketoacidosis has to be prevented. And there is interactions between lopinavir and ritonavir when you are using this drug along with these SGLT2 inhibitors. Again, DPP-4 inhibitors, lopinavir and ritonavir and atazanavir has to be avoided. And metformin, when you use lopinavir, there is an interactions. And these are the drugs which the disadvantages are shown here. GLP receptor agonist, risk of gastrointestinal side effects and aspirations has been documented. Please, sulfonylureas, as I said, role of hypoglycemia has to be looked out for. Glitazone, fluid of retention of fluid and heart failure has to be taken care of, especially when you use favipiravir. Insulin, if you use hydroxychloroquine, you should avoid, you should think of hypoglycemia, and especially in diabetic ketoacidosis or where there is hyperglycemia due to drugs or intravenous administration of insulin is required where they need high doses to control the blood sugar. Usual at home anti-diabetic therapy can maintain patient receiving treatment in hospital with regular caloric and fluid intake according to the clinical status of individuals, risk of drug-related adverse effects, interactions between anti-diabetic agents and drugs used for the treatment of COVID-19. However, insulin is the preferred agent for glycemic control. Patients with diabetes receiving treatment in hospital, and its use is mandatory in critically ill patients. So, friends, to conclude, diabetics are at a greater risk. There is a worse prognosis and the mortality rate is very high, almost 4 times patients who do not have diabetes. The syndromic care of and treating diabetes with COVID. Antiviral drugs has to be used with caution because they have interaction with various drugs, and glucose lowering treatment with COVID-19 and diabetes. Thank you. Thank you for your virtual attention in these days. Thank you, Amit, and the whole committee for giving us this opportunity to talk about a very important subject of diabetes and COVID. Thank you.
Thank you, sir. Dr. Patankar, please.
Yeah, sir, thank you so much for covering the topic of diabetes in presence of COVID. I think everyone will have to introspect now about how the diabetes can be treated in post-COVID scenarios. So thank you so much, sir. And I hand it over back to admin and Dr. Amit.
Thank you so much, sir. It was a pleasure to listen to you as always.
Thank you, Amit, and your whole team for putting up this program of EMAPCON. You will recollect that we were also instrumental in doing EMAPCON in Mumbai.
Yes, sir.
In the past, and I must congratulate Dr. Alka Deshpande and others who have had the initiative of starting EMAPCON. Thank you.
Thank you so much, sir. Thank you so much, sir. Bhavik?
Yes, sir, sure. For the next talk, we have Dr. Shashank Joshi. He's going to be talking about COVID care, what's new. For this, I would like to call upon Dr. Shirish Chavan. He's a senior physician from Miraj Sangli. He has been he has held numerous faculty positions in national conferences. He's a senior MAP member and a past president. On to you, Shirish, sir.
Yeah. Good morning. Herewith I'm introducing Dr. Shashank Joshi, sir. Actually, Dr. Shashank Joshi, sir, do not require any introduction as such, but to complete the formality, he is a Padma Shri awardee.
Dr. Chavan, we can't hear you.
He needs to unmute, yeah.
No, he is already unmuted. Bhavik, can you? Yeah, Dr. Chavan is. Sir, we couldn't hear you.
I'm already unmuted.
We can hear you. Yeah, can you go ahead, please?
Yeah. Dr. Shashank Joshi, sir, do not require any introduction. He is a Padma Shri awardee winner, gold medalist in his entire academic career, and he is presently Dean of Indian College of Physicians. You all know that he is the main force behind the Mumbai COVID task force. He is past president of API. He is a past president of API, past president of RSSDI. He is a president of International Diabetes Federation of IDF, and he is a senior endocrinologist, Lilavati Hospital, Mumbai. I am presenting Dr. Shashank Joshi. I request sir to talk.
Thank you, doctor. And I would like to thank and place on record my heartfelt thanks for, Team MAP, everybody right from Amit and everybody that, this is a COVIDized MAP and it's under COVID times in new normal. So I am sure everything of this has been covered. And am I visible and are my slides visible? That's the two questions which we always ask.
Yes, sir.
Yes,
So,
you are
I
audible,
speak
you
for
are
the
visible.
24th of 25th, and I want to wish everybody Vijaya Dashmi. We had Professor Siddharth Shah talking to us about COVID and diabetes, and I have to talk what's new. and what's something different in COVID, because you have been COVIDized last 2 days. And I think each aspect of COVID has been covered by respective people here on the dais. And thank you, Dr. Chavan, for your kind words. And I want to thank each office bearer of MAP, the Maharashtra Association of Physicians, for allowing us. Maharashtra has led from the front. And I think on planet Earth, it is the 4th largest country on planet Earth is Maharashtra in COVID. So after United States, it is India. After India, it is Brazil. After Brazil, it is in Maharashtra. So Maharashtra is actually the world number 4. So is it a pandemic? The answer is yes. Is it a case-demic? Which means, are we detecting and just simply labeling cases? Because 85% of cases are asymptomatic. So are we just multiplying these numbers of cases? Because 85% of people with COVID are going to become okay, whether you treat them or you don't treat them. And everybody is having a field run on that. So probably it is. If you are, because ICMR set the viral threshold, cycle threshold at 40. If you reduce that cycle threshold from 40 to 24, because we don't know what is the true infectivity dose and the inoculum needed for infectivity. So we know that who is infectious. Somebody whose viral load is below 24 is infectious. Somebody whose viral load is about 24 up to 28 may be infectious. Below 20, about 28, if the viral load is there, it may not even be infectious. So this is a question which we need to answer. And then if you are detecting somebody with a RT-PCR positive who has a viral load of 33, 32, 31, 28, are they really generating and throwing out infective particles? Are they having an actively multiplying virus? And are they having a true disease? That is a question, which is a research question, which we don't have answers to. The antigen test picks up only the people whose RT-PCR is about 24. Is there an infodemic? Yes, there is an infodemic. MAP also has had an infodemic of COVID information. And every day we are having this infodemic. Every day on, all newspapers, media, channels, every media you can think of, we have information overload. So, there is a clear infodemic which is there. I personally feel there's a clear case-demic, and people whose viral load is probably below 28 or 30 with the cycle thresholds, they do not are having infective particles, and they may have just that silent so-called disease, or the asymptomatic carriers. And we have not really qualified these asymptomatic carriers. So we are understanding in the 3rd season of COVID very little about COVID. As I said, I used to do infectious diseases in my HIV days. Then I moved away from it completely into my field of endocrinology. I'm back into it now, only to see us through this pandemic. So clearly the pandemic is there because of the case-demic, which is decided by a cycle threshold based on RT-PCR value. And there is information overload. Most of the information is non-peer-reviewed in non-peer-reviewed journals. So one only characteristic about SARS-CoV-2 virus is it is predictably unpredictable. That's the only statement which holds true. Everything else what you talk about SARS-CoV-2, whoever you might talk about, it is not correct, because all the evidence base which was generated in March, which was generated in Jan, which was generated in June may change, because it's a changing pandemic. So that's something which we need to recognize. Are we testing too much? Are we testing too little? Well, people say we are testing too little globally. So are we going to test everybody in India? The answer simply is no. We cannot test everybody in India. These are my personal opinions. These are not opinions of any association, of the government or anything. I think we cannot humanly test every human being on planet Earth. Are we testing too little? Are we testing too much? I think we need to test sensibly. I don't think we are either testing too much or we are testing too little. But we clearly need to test sensibly. So the test has to be symptom-based, and when you want to test, isolate and treat. So the testing threshold and infectivity is a research question. And that's a research question for researchers and virologists to answer us. That should the cycle threshold value be 24 or 40? And because the infectivity only goes up after the cycle threshold drops below 40, 24, and that's something which we need to know. And look at vulnerable population. So if somebody is RT-PCR positive, but his vulnerability score is poor, for example, somebody is 25, is not obese, doesn't have hypertension, diabetes, has a silent asymptomatic disease, he's going to recover. You really don't need to know rocket science on that. And then whether you give him a Coronil from Ramdev Baba or whether you give him a Favipiravir from the best agent, they are all equally the same because the patient is destined to recover. So who is the one who is going to progress? So do we have answers on that? Do we have evidence based on answers on the progressors? Who will progress? Yes, vulnerable group above a particular age, and any age above 30 might progress. But above 55, the likelihood of probability of progression is more. Okay, how do you detect progressors? Do we have a magic formula for them? Can a blood group predict them? Are we astrologers? Now we have become medical astrologers because there is no science. It's all quasi-science. Okay, we need a good RCTs, and we don't have good RCTs. We don't have placebos. We have these solidarity-like trials. We don't have placebo, don't have blinding, which allow, they are called adaptive trials. So, jo mangta hai karo. So that is something which you need to recognize, that you need to have a very clear direction, very clear evidence base, very clear individualized decision making. So obviously the decision making in COVID is very individualized. Every case is different. Every case needs to get a phenotype profiling, a biomarker profiling, and then take a clinical decision based decision for that case. So we need to test. If a test is positive, we need to trace at least 20 of those contacts of that person, and that person needs to voluntarily disclose. Are we doing counseling like HIV days? No, that's wrong. We need to counsel that person pre-test. We need to counsel that person post-test, and we need to ensure that between the test duration, he contacts all his contacts, gives a list to the government, and ensures that those people at least self-isolate. Because if he has spread the disease to others, at least he can then mitigate it. That's why there has been virtually like a community spread in our population, which is sad. So if you really want to test, we need to do a pre-test counseling. We need to tell the individual we are testing that please ensure that contact all your contacts to state that you are doing a test, you could be positive or negative, and you need to stay home and take adequate care. This will do damage litigation and prevent further spread. And then of course, isolate for a good 10 days, because after 10 days, you don't need to isolate because the virus is not replicative. And if the person is positive, you need to do treat and care based on the vulnerability quotient, based on the comorbidities, and based on what has to be done. So what works? Early disease, a lot of things may work. For viral clearance, a lot of things may work on, on symptom recovery, whether it is a hydroxychloroquine, azithromycin, whether it is a ivermectin, doxycycline. Again, both of them have very poor evidence base, or whether it's a favipiravir, which also has a very poor evidence base, but it clears the virus faster. That's all they claim. Okay, all these may work, or any immunoadjuvant will work, but we really don't have data to say beyond reasonable doubt A, B, or C antiviral works. But if in the first 24, 48, or 72 hours, you hit an antiviral, hit hard, hit early, it may work. The problem is not early disease. Problem is middle disease. The middle disease is the disease which comes between the 4th day or 5th day to the 12th or 14th day. That is the tricky time when you might get hypoxia, desaturation, and you need to identify that. And the single most important test is a 6-minute walk test. You do a 6-minute walk test 24/7. And if there is a desaturation drop and not done by a Chinese pulse oximeter, okay, and done appropriately, because the most common thing is somebody shows me and calls me with a saturation of 76, and that's not true because that person is absolutely fine. He has not put the pulse oximeter correctly. He's using a Chinese pulse oximeter. The battery has dried out and you are getting an erroneous reading. Do a proper test. If there's a 3% drop in the saturation, if the saturation is less than 94%, go to a nearby doctor or a hospital facility and get treatment and care. That's important to recognize. So detecting that hypoxia is very crucial. And in the late disease, it's all about intensive care, critical care, and critical decision care making. There we only know one drug which may work in oxygenated and mechanically ventilated cases, which is dexamethasone. That too from one trial. Okay, so again, it doesn't have multiple trials to reproduce. Okay, in mechanically ventilated patients, in people who got oxygen, whether dexamethasone work, that is a question markable decision. Okay, and otherwise, whether anything else works, absolutely we don't know. Maybe it may work on symptom recovery, maybe it may work on clinical recovery, maybe it may work on biomarker recovery. But as far as mortality goes, 28-day mortality. Again, here they have quantified 28-day mortality. Ideally, it should be 28-day mortality and 90-day mortality. That data also we don't have. Nothing probably works. So this is a unique virus. We all have studied virology in the last 2 days because of the infodemic and infodemic explosion. Well, it docks on the ACE2 receptor. From the ACE2 receptor, it causes a lot of conformational changes and hijacks the host human cells, whether it is the pneumocyte, whether it is the cardiac myocyte, whether it is the gut epithelium, whether it is testicular tissue, whether it is renal tissue, it hijacks it. And obviously, it's most effective in those pre-symptomatic stage, in the weeks, 10 days before we actually start picking up symptoms. So those are the spreaders and super spreaders which public health experts keep on talking about. And then probably the pattern, once the symptoms develop, now at least have evolved as a reasonable predictability. At least we know who will progress, who will not progress, so on and so forth. But the antibody response is not a typical antibody response. We have not looked at the IgD at all. IgM responses are poorly studied in the coronavirus. The IgG1, 2, 3, and 4 have again been poorly studied. These plasma trials have failed only because the appropriate way of the neutralizing ability of the antibody was not evaluated. If we had done a proper quantification of neutralizing antibody with a good methodology, probably convalescent plasma in the first 9 days may work. It can compete with a drug like remdesivir. So obviously, they make antibodies. We have data to show that antibodies come up, whether they go back, and whether there is a correlation between viral and immunological dynamics with symptomatology, we don't know. But probabilities, we know a little bit of that. So that's something which we know. But clearly with age and disease severity, we know that the magnitude, there's a limited understanding of magnitude and duration of antibody responses in persons with different disease severity, different genetic backgrounds, comorbidities, age, and infection history. We clearly know in one study with mild symptoms who recovered had a higher neutralizing antibody titer and spike binding titers. Just antibody, neutralizing antibody titers are not important, spike binding, than in older and middle-aged patients compared to younger patients. And we also don't know whether these higher neutralizing antibodies observed in the older patients were protective or not. We also know that the higher IgG titers in patients with severe disease versus non-severe disease, 2 weeks following symptom onset, what is the suggestion of that? We have absolutely no idea. While another study published said there was no difference in the IgG antibody levels between patients with mild to moderate versus severe disease. So antibody status is again unknown entity, and we are learning more and more about it as times come by in some very elegant papers. So what do we know about immunity? The immune correlate, it's an RNA virus. It docks into and activates the host innate immune response. There is a dendritic cell activation which uptakes the viral antigens, and clearly adaptive immunity kicks in. The B cell and the memory T cells are clearly there, but we are understanding them a little better. I'll talk a little bit later about that. But the cytokine production is clear cut, and we know that there is a cytokine storm. The Treg cells are clearly linked to an inflammatory response because we clearly know that there is a strong inflammatory response. So this is something which we know beyond reasonable doubt. There is a lot of CTL response where there is a killing of infected cells, and there is a clearly on the follicular cells, we get induction of antibodies. So these things we know very clearly now. And that cytokine storm which we get is something which we want to mitigate and prevent, because that probably has been linked to mortality, and that's something which we need to prevent. So the typical T cell response, which is what will base everything on immunity of SARS-CoV-2, is something which we need to know. Okay, and this is an assessment of proliferation of CTV and functionality of the interferon secretion of SARS-CoV-2 specific T cells from convalescent patients, exposed family members, and healthy donors. If you look at T cell stimulation of peptides spanning the immunogenic domains of spike, membrane, and nucleocapsid proteins, which are shown here in the graphs, which was a very elegant paper published by Skinner et al. In the Cell journal. Here clearly you say that it is the T cell response, whether it is to the spike protein, to the membrane protein, or the nucleocapsid protein, which clearly will have something to do in the future. And if that is there, you might have a neutralizing antibody which may be negative, or IgG may be negative, but still there could be a generation of this. And that's what is the summary of the T cell response. 100% of individuals with prior severe COVID and 87% of people with mild COVID had a specific memory T cell response in the convalescent phase, actually 1 to 2 months after disease onset. So that's clear cut. So for 1 to 2 months or 3 months, there is some degree of T cell response. We have studied CD4, CD8 T cells during the HIV pandemic. And here you can see that in seronegative individuals who have had SARS-CoV-2, There are SARS-CoV-2 specific CD4 and CD8 T cell response, recall, which was present in 41% of seronegative individuals. So antibody may be negative, but you can still have a SARS-CoV-2 specific CD4, CD8 T cell response. And that's something which we need to recognize, because in the convalescent phase, with a person with mild COVID, with exposed family member, with healthy individuals, you might have generated some amount of a T cell response. And another study which has been shown, again, very good data. Again, this is not peer-reviewed study. Most of the studies are not peer-reviewed. They're all put on a preprint version. The spike-specific memory CD4, CD8 T cells were maintained for 3 months following symptom onset. So at least we know that if you get an exposure to SARS-CoV-2, you will have some degree of protection for 3 to 6 months. Autopsy studies are very, very limited in the COVID pandemic. In India, virtually none. Necropsies also have not been done. What is the data which revealed in autopsies? Organized microthrombus, alveolar damage. So that's clear cut. It's a coagulopathy. So the single most entity which kills in COVID is the thromboinflammation and coagulopathy. And that's really the damaging thing. And the single most pathognomonic feature of COVID is endothelitis. The SARS-CoV-2 binds to the host cells via ACE2 receptors. There are high density of ACE2 receptors on the endothelial cells. And there are viral inclusion bodies of SARS-CoV-2 which have been documented in the autopsy series of endothelial viral inclusions in endothelial cells. So endothelitis is the pathognomonic feature of SARS-CoV-2. We have a lot of repurposed drugs used for something else being used in COVID. And your guess is as good as mine. Prophylaxis, hydroxychloroquine, ivermectin. Do we have data? Answer is no. Is it anecdotal? Maybe yes. Are there recommendations on expert opinion? Probably yes. Is there a role for hydroxychloroquine? Probably yes. There are some case control data. Data is conflicting. And what about ivermectin? No data available. So as far as prophylaxis is concerned, there is some data in hydroxychloroquine. RCT evidence does not exist. Probably it may work. We don't know. It may limit the disease limitation, but it's an unanswered question. So prophylaxis, we have nothing. In the first 9 days, antiviral drugs might have a role. Earlier, the better. Okay. Whether they change the disease biology, whether they modulate the cytokine storm, we don't know. Can plasma work here? Yes, it can. Can remdesivir work here? It can. Can favipiravir work here? It can. Okay. But the data is again clear cut. And probably after 7th day, there is a role for immunomodulated drug. The king of the drugs there is steroids, only if there is oxygenation and some amount of non-invasive ventilation already set in board. Otherwise, it is very difficult. So remember that a lot of dyspnea can come in 40% of symptomatic patients, and severe illness in 14% of symptomatic patients, and critical illness in 5% of symptomatic patients. So we all know the initial acute viremic phase does not need steroids. Then the host inflammatory response comes up, and then we get a post-COVID syndrome. So the timing is the key. You know, the first 3 days, it's oral antivirals. Day 3 to day 10, probably injectable antivirals can work. Beyond day 8, 9, no antiviral is going to work. So if you're giving it afterwards, I think the data is clear cut that there is no actively replicating virus. It's completely redundant to use these drugs. Steroids, 2 groups. British group says dexamethasone, and the American groups from the Henry Ford say it is all about methylprednisolone. Again, RCT is lacking there, except dexamethasone, which has recovery data, which is pretty robust. Well, low molecular heparins, again, data is lacking on it, but it probably saves life. It is D-dimer driven or a DVT dose. What about IL-6 modulators? Again, the data there has not been very great, but what works is high flow nasal oxygen, prone positioning, and mechanical ventilators have poor outcomes. Plasma therapy will still hold true if it is used early. Don't give up on plasma so fast. And I don't think the next trial of plasma also will come very supportive. IL-6 blockers can help in select cases. Hyperbaric oxygen can work. And as Dr. Siddharth Shah said, in comorbidity care, statin saves life, aspirin saves life, insulin saves life, gliptin saves life, and nutrition saves life. The best biomarker for me to predict, and I'm not an astrologer, is red cell width. If I see on the CBC red cell width and NLR is abnormal, I know this patient is going to deteriorate with CRP. All I need is that. I don't need really a ferritin LDS to back me up. I don't need an IL-6. And IL-6 and D-dimer values have to be very appropriately done. If they're not done properly, it can be a disaster. Well, a lot of people ask me that should we stop remdesivir? Absolutely not. In your cases, you have to individualize the patient. Remdesivir ACCT data is randomized placebo-controlled data, which was published by NIH. And the US FDA approved remdesivir based on this slide. because Solidarity trial has no placebo, it has no double blinding, it has limited data monitoring, it has no diagnostic confirmation of infection, it has no timing of symptoms duration before treatment initiation, it has unknown baseline physiological severity, unknown supportive care provided, unknown healthcare capacity status for enrolling sites. So whichever site wanted to do whatever they did, and it is not yet peer reviewed and published. Clearly, I think you should not get carried. It's an interim data, and they themselves are continuing, including ICMR. So I think we need to see the full data, but remember, take it with a pinch of salt. Even the covalescent plasma trial is an open trial. It is not a placebo double-blinded trial. We are pure scientists. If you want to generate evidence which is of level A with confidence, you need an RCT, and that's not happening. So in mild disease, very early, maybe favipiravir might work. It can definitely improve viral clearance. Hydroxychloroquine, azithromycin, probably there's data to show that it also works, but it has some challenges with QT prolongation, over-exaggerated by the Europeans and Britishers on the Western media. Doxycycline, ivermectin, off-label. We are about to publish our data also, but Bangladesh and us, we have an RCT, but again, till the data is out, we can't comment on it. Adjuvants like C, D, and zinc probably have a role. Aspirin probably might have a role. Moderate disease, you can give favipiravir, but remdesivir comes in, covalescent plasma comes in. There may be a role for steroid in appropriate cases, oxygen, prone positioning, high flow nasal oxygen, low molecular heparin like Lexane, 40 milligram OD or BID, which can be D-dimer driven, and occasionally a itolizumab or a tocilizumab may be needed in a given case. In severe cases, probably Itoli subcute. Now the new CHO variant is available. That's our treatment of choice rather than using a tocili because it may have controversial data. And then, of course, you can use in select cases on compassionate grounds many other drugs, including hyperbaric oxygen, which is done only in one hospital in Bombay at Hiranandani, and ECMO can be another choice. Remember, don't forget comorbidity care. And we have seen a lot of patients with diabetes, which Dr. Siddhacha alluded to, with diabetes, hypertension and diabetes, CKD, CAD, CLD, COPD, obesity and age. All these can kill. And those are the groups we need to recognize. We are going to get a tsunami of lung fibrosis. We are going to get a lot of cardiac complications. So we need anticoagulants for a longer time. We will get post-traumatic stress disorder and a lot of mental health issues. So counselors should be a part of your fatigue part. You will get a lot of fatigue where a lot of ashwagandha, N-acetylcysteine and coenzyme Q will be used. And you will need a post-COVID OPD. What worked in Maharashtra is basically screening the vulnerable groups, going into the slums and screening out people who had low oxygen by a pulse oximetry. The 6 points of monitoring in every COVID care is temperature screening, pulse, respiratory rate, blood pressure, pulse oximeter for oxygen saturation, and 6 vital sign is glucose. If you do these 6 things on a vulnerable cohort, you can catch them early, treat them early, hit hard, hit early is the dictum. Well, non-COVID care is equally important. We had field hospitals, non-COVID care and food and shelter. So I'll stop here. COVID will stay. Controversies with COVID will stay. I'll be happy to answer any questions. I have tried to save some time because of things, but I felt that I should stop a little early and maybe take a question or two. And then, of course, you can proceed with your questions. I can say my good friend, Dr. Vijay Panikar, I call him Paniglitazone, is arrived. My teacher, Dr. Siddhacha, gave a very elegant talk on diabetes, but he didn't touch. Dr. Panikar, he mentioned you and said the pioglitazone part will be handled by Paniglitazone. And you know, my good friend Amit Saraf, Mangesh is there. I can also see Rajiv Soman is gearing up for his presentation with Dr. Devgaonkar. So I thank all of you all from the MAP team that, you know, COVID is all here to stay. That is why we are meeting virtually. I wish things change and we can meet physically. I am quite optimistic that we are hosting a virtual EPICON in the 4th, 5th, 6th and 7th of March as a hybrid model. And I feel that if things are good in Maharashtra, we might even actually host you up in a hotel and we invite you for the virtual EPICON, which is going to come up on 4th, 5th, 6th and 7th of March, coming up headed by Dr. Siddhacha as the chairman of our team, with of course Dr. Kamlesh Tiwari, who is our president as a scientific, and I'll have to do the CME, with ably supported by Dr. Mangesh Tivaskar Agam and Dr. Bhagwati. But I welcome you all to virtual EPICON. I didn't have a slide on that. And I can see Dr. Rajesh Patil also, Dr. Mahavarkar also. So thank you so much.
Sir, it was as always a pleasure to listen to you.
Yeah.
I mean, Dr. Joshi has always been I would say the final or the last word in a lot of platforms. Once he speaks, he sums it up in so well. Almost the core context of the conference is taken. And on this platform, he's done so not only as a senior endocrinologist, a senior task force member of the state of Maharashtra, not the city of Mumbai alone. He was instrumental in also talking to the chief minister on his YouTube channel. Every Sunday, he does a YouTube channel at 12 noon. In fact, we were grateful to have him just a few minutes before his YouTube channel begins. And sir has been a national figure in
Before he joins that YouTube channel, I want to have a question to Shashank. Shashank, talk to us about your Italy experience. Because I just read your publication on Italy along with some of the Biocon guys. So
it is a little better than it. So now the new preparation can be given subcute like insulin, and it is a pan T cell agent. So it is not an IL-6 blocker. It activates at much earlier in the immune pathway. We can discuss that offline, but it's a little better molecule. The phase 2 data is a RCT, which is now undergoing peer review. I'm author on that publication. Milind from KEM, Dr. Rosemary from Nair, Dr. Guleria from AIMS, and Dr. from MAMC. All they have done a RCT for phase 2, but that's a very small trial. But they have shown mortality data, which is positive. They need to do a larger trial with 400 patients, which they are undergoing. It probably is again a cytokine modulating agent. But as I said, everything in COVID is predictably unpredictable. So it is like aaj ka taja khabar and aaj ka naya dawai. Okay, but as I said, that we have to use clinical common sense and we have to be guided by individualized care. But itolizumab had a problem. If it was given IV, it had to be given very slowly. It could cause a lot of rigors and reactions.
Yeah, a lot of patients.
If you give it subcute with the new molecule, probably it causes less of the rigors and reactions. So try the new CHO compound which is coming up. But that's a little better than tocilizumab. Tocilizumab still should not be given up. In individualized cases, it has saved lives, and so has remdesivir. But as I said, nothing has impacted mortality except probably dexamethasone in a single trial. I think the only thing which works in COVID is oxygen, prone positioning, and maybe a little bit of dexamethasone, a little bit of heparin, and probably one of these agents if used early. Also remember, use them early when the oxygen saturation is, or the requirement is going up from 4 liters to 15 liters in less than 24 hours. That's the time to hit early. If you use them late, or if you use them after ventilator, nothing is going to work. Then probably only dexamethasone and supportive care. So what is worked in COVID is oxygen, supportive care, and prone positioning, and maybe a little bit of low molecular heparins. If you ask me, is there data? There's no data. Do you have an RCT? I don't have an RCT. It's all based on an indirect presumption, based on autopsy data, based on thromboinflammation, based on the sudden deaths. Okay, is there any data on novel anticoagulants? None. But people are prescribing them left, right, and center. But there's no data to support that. Okay, it's all based on anecdotes, and it's all based on your gut feeling. Okay, so we need to generate data. There's a huge need to generate India-specific data, and we need to generate some hard science in COVID care. Even if it's observational, it's good enough. Even if it's case control, even if it is cohort, it's good enough. You need not have an RCT all the time. Remember, Solidarity was not an RCT. It was an adaptive trial. Okay, without any major, double blinding or placebo or anything.
Shashank, this second wave is expected. Do you expect it to be more severe than the first wave, or it will be milder as compared to the first wave?
Honest answer is your guess is as good as mine. I am not an astrologer. I'm a scientist. and I'm telling you very frankly, in north of India or in Europe or USA, it is going to be probably there in terms of number. Whether the disease or the virulence will be worse, unlikely. It is likely to be milder, but the people who get it get a full-blown syndrome. Remember, that's something which we need to recognize. Will Mumbai get it or Thane get it? Unlikely. Because we are in a tropical country, in a tropical humid zone. So we got the peak in moisture time. That was monsoon time. So I feel that we are out of it. But there's going to be so much of cross transmission. So that's why probably our peak might come in June, July. But I think we are out of it.
Has the herd immunity
honestly, the numbers and the trends which we are seeing. And if we have the only single thing which helps COVID is COVID appropriate behavior. Even if you take a vaccine efficacy is 65-70%. Okay, while the mask efficacy is 95+%. So if you mask well, do sanitization, and take care of your own family, have a COVID appropriate habit, I think you can still mitigate this second peak. It's very possible.
Is the herd immunity?
Herd immunity is a concept generated by WhatsApp University. Herd immunity does not exist in COVID care unless and until we get a critical mass of T cell response, which I showed you, okay, which might be there. Now, there is data from TIFR from Mumbai city in slums that there are slums which have antibodies beyond 80%. India and Mumbai is the only place on planet Earth which has documented more than 50% of antibody positivity. That IgG positivity, whether it translates with a T cell response, which does not decay, if it is sustained, we will know. So the first answer on herd immunity on the good question will come from India, probably from Dharavi or urban slums of Mumbai or Thane. Okay. For example, you are staying in Thane, you have Mumbai, and Mumbai is a very population dense place, and you see that COVID is not there as much as you expect. Or I can
Every day we are reporting 3 or 4,
we have
not
seen
more
the
than 4
Malegaon
or 5
model,
cases.
and for Malegaon,
Yes.
again we don't see the COVID coming.
Shashank,
Yeah, yes,
Hello.
Naren.
yes, what are the chances of getting reinfection?
Exceedingly rare, unless you go back in the viral environment. Probably
sir, what is the role?
reinfection is not a known entity. The number of cases which are documented are very few. And even if the cases which are documented from India, I'm very skeptical because I don't know how they picked up the first genomic analysis. See, I got COVID today. I have picked up my blood. Am I going to store it for genomic analysis? Then second time I get it, I will again store it for genomic analysis. It's very difficult to prove reinfection. It's possible that the first case could be false positive. Because sometimes you can get a false positive with the whole generation of the RT-PCR system, very rarely.
Role of long-term anticoagulation. Sir, what is the role of long-term anticoagulation?
In high-risk cardiometabolic cases, you might need to give it for 1 to 3 months.
Okay. Sir, it is a very...
Shashank, excellent talk. I think the take-home message is wear a mask.
Yes.
Cover your nose and mouth, and Corona can't enter. You can go to Corona's house, attend a party, and come back. Nothing will happen.
Yes, I say that is the place where everybody has to learn. You know, most of the people are found there covering their face, covering their mouths rather than noses. You know, that's the way we wear masks. You know, mostly difficult.
That is true. So,
Thank you very much, sir.
Dr. Panikar is in blue. Today I am also in blue because of Dr. Panikar.
Yeah, but
Thank you so much, sir.
Today's color is
Wonderful.
purple, so, but I don't have purple.
It drives the blues away.
Anyway, happy Dashara to everybody and bye.
Thank you so much, sir.
Thank you, sir, very much.
Happy Dasra, happy Dasra.
Happy Dasara. Bhavik?
Yes, sir, sure. So for the next talk, we have Dr. Vijay Panikar, sir. He's going to be talking about re-examining the role of TZDs in present clinical care. For this session, I would like to call upon Dr. S.M. Rudrakshi, who is going to be chairing this session. He's an established internist based out of Solapur for the last 25 years. On to you, Rudrakshi, sir.
Thank you. Namaskar, Solapurun. I first of all thank organizing committee of eMAPCON 2020 for inviting me as a chairperson, and also congratulate them for organizing excellent academic sessions. Now you are going to listen to well-known speaker Dr. Vijay Panikar on re-examining the role of glitazones in the present clinical care. Dr. Vijay Panikar is the senior diabetologist in Lilavati Hospital of Mumbai. He is Vice President of National RSSDI and Organizing Secretary of National RSSDI 2021. He is the past President of Maharashtra State RSSDI. He is postgraduate teacher in diabetology and national speaker. He has numerous publications in various national and international journals, and he is well known for his wittiness. So I present Dr. Vijay Panikar to you. Sir, over to you. Please carry on. Thank you.
Thank you very much. Can I share the screen?
Yes, sir, surely. Please go ahead.
Good morning, ladies and gentlemen. At the outset, let me wish all of you a very happy, healthy, and nice Dasera. When I looked at the program, I found the entire program was COVID, COVID, COVID all the way. And I rang up Amit this morning. I said, everybody is talking on COVID. I think I am the one odd man out here that you are giving me a topic which is other than COVID. He's saying, sir, there is COVID everywhere. So we thought, let us have some fresh air in COVID, because you need ventilation also to prevent COVID. So that is how, at the outset, let me thank Dr. Mahavarkar, Girish Rajadaksha, Narayan Devgaonkar, and of course, Amit Saraf for having invited me to speak on the glitazones in clinical care. And of course, I will touch on the role of glitazones in COVID also. Let us look at the beta cell. This is from the UK PDS. There is a steady decline. At the onset of diabetes, 50% of diabetics, all the beta cells are already gone. And there is a steady apoptosis. And this is what causes the progression of diabetes. These are 12 studies using sulfonylureas. I'm going a little fast. 12 studies using sulfonylurea. Initial HbA1c comes down very nicely. And then you see there is a streak, it goes up. That's because the beta cell is dying. There is apoptosis and that is the progression of the disease. But look at these 8 studies using a glitazone. There is a good decline in HbA1c and it remains there. There is a durability of control. What is it telling us? That somehow this molecule is preserving the beta cell. And what actually kills the beta cell? Glucotoxicity, any hyperglycemia can do that. But most important is the lipotoxicity, elevated free fatty acids, which enter the beta cells and damage them. And insulin resistance is the driving force for all this. So what is the effect of a glitazone on beta cell preservation? Direct effect on beta cell, amelioration of insulin resistance, reduction of free fatty acids, but this in yellow is most important. Mobilization of toxic lipid metabolites, free fatty acid coenzyme A, DAG, ceramides out of the beta cell. This is the lipotoxicity. And this is what the glitazones do to preserve that beta cell. Of course, there is reversal of glucotoxicity. There is a good durable glycemic control, improves the pro-insulin-insulin ratio, decrease the prevalence and severity of amyloid in beta cells. So that is the preservation of beta cells. Now we are looking at another major epidemic, which is just waiting to hit us, and that is NASH, or non-alcoholic fatty liver disease. And there are a lot of trials with pioglitazone. I will just quickly go through this. All these studies have shown benefit of pioglitazone in NASH in preventing fatty liver and in treating. And this is the American Association for Study of Liver Disease, which says pioglitazone improves liver histology in patients with and without type 2 diabetes with biopsy-proven NASH. Therefore, it may be used to treat these patients. So we can save the beta cell by using glitazones. You can prevent. Today, if you do a sonography on your patients with type 2 diabetes, especially those who have a central obesity, you will invariably find the sonography report telling you that there is a fatty liver. And the pioglitazone can prevent and reverse that and prevent the progression. Let us look at the Indian scene. We see diabetes coming in younger and younger people nowadays. This is the lifespan of an Indian, and approximately 70 years. So you have a 30-year-old non-diabetic, he is expected to live beyond 70 years. But if you have a diabetic at 30, he stands to lose 14.5 years of his life. So when you treat a diabetic, I think you should be looking specifically how you can make him live longer, well beyond 70. And what is he going to really die of? 80% of the patients with type 2 diabetes ultimately die of a macrovascular disease, whether it is a myocardial infarction or a stroke. Now the big million-dollar question is, does tight glycemic control prevent macrovascular disease? We have the UKPDA study, which after 10 to 20 years showed that all-cause mortality only reduced by 6%. No, it's not significant statistically. Myocardial infarction reduced by 16%. But after a 10-year follow-up, you find that there is a slight improvement in the all-cause mortality, which becomes statistically significant. So what does this tell us? That if you have a good glycemic control for a very, very long time, you can prevent cardiovascular mortality and all-cause mortality. Let us look at the major studies of intensive glycemic control. You had the ACCORD Advanced VADT, where all they tried to get the HbA1c to below 6.5 in the hope that we'll have good outcome. But what did it show? Absolutely no benefit, except in nephropathy in the ACCORD and Advance. And in the ACCORD, there was an increased mortality due to which the study had to be stopped. So what does, if you look at the summary here, UKPDS and all these study, initial phase, none of them show any cardiovascular benefit. In fact, there is increase in cardiovascular mortality with ACCORD. But long-term follow-up, UKPDS microvascular CVD reduced, mortality reduced with UKPDS, like I had shown you, about 16%, DCCT none. So what, this is another study, the Nurses Health Study, 20 years follow-up, almost over 1 lakh of nurses. And what were they looking for? Relative risk of myocardial infarction and stroke. Those with no diabetes, the chance is 1. If there is diabetes at the baseline, they have a 5 times greater chance of getting a myocardial infarction. But before the onset of diabetes, these are people who got a myocardial infarction and then subsequently became a diabetic. I won't go into the details, but what this tells us is that cardiovascular mortality problems begin 15 years before the onset of diabetes. So what are we talking of? Just glycemic control. This is going on much before that. So what is the big message in cardiovascular disease? That good glycemic control does not prevent heart attack. You can die of a heart attack even with an HbA1c of 6.5. So where are we? What are the risk factors? Insulin resistance, hypertension, elevated LDL cholesterol, small dense LDL, high triglyceride, HDL. Now this kind of dyslipidemia is again driven by insulin resistance. Chronic vascular inflammation driven by insulin resistance. Proatherothrombotic state driven by insulin resistance. So what is the role of insulin resistance in microvascular disease? 83% of diabetics will have insulin resistance. And insulin resistance promotes atherosclerosis even before it produces diabetes. These two studies have shown that it is an independent risk factor for cardiovascular disease, myocardial infarction, and stroke. Now look at insulin, clinical manifestation, insulin resistance, glucotoxicity, lipotoxicity leads to type 2 diabetes, dyslipidemia, classical hypertension, and so on. And this leads to diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, stroke, and so on. Everything is driven by this. Is the Indian phenotype different? Yes, we are thin, fat Indians. This is from UKPDS, which shows that Asian Indians have the highest level of insulin resistance. These are n number of studies which I have quoted, and it shows that insulin resistance has been demonstrated even during adolescence or even before that. Is there evidence that treating insulin resistance can help? What are the options for treating insulin? Non-pharmacological is diet, exercise, and weight reduction. Pharmacological is metformin and pioglitazone. These are the diabetes prevention studies, patients with IGT, with diet, exercise, good improvement, showing that treating insulin resistance does work. Pharmacological intervention, all these studies have shown that they can prevent the new onset of diabetes. But this is the most important study which has just come a couple of years ago, the IRIS study. What was the IRIS study? It was patients who had TIA or ischemic stroke, meaning they already had a macrovascular disease. They were non-diabetics, and they checked insulin resistance if its HOMA is more than 3, and they were put on pioglitazone 15 to 45 milligrams versus a placebo. They were looking for fatal, non-fatal MI and fatal, non-fatal stroke. At 5 years, what do they find? That the recurrent stroke reduced by 24%, myocardial infarction reduced by 24%, and new onset by 52%. So this was the first time that a study has shown that directly treating insulin resistance, you can have a cardiovascular and cerebrovascular event reduction. A post hoc analysis of the IRIS randomized trial was looking, does pioglitazone reduce cardiovascular events in pre-diabetic patients? So here, there were almost 2,885 pre-diabetics out of the 3,800 patients who went onto the IRIS trial. And here what they looked at, those who had 80% adherence to treatment. And what did they find? Stroke and myocardial infarction reduced by 40%, stroke itself by 33%, acute coronary syndrome by 52%, new onset diabetes by 80%. And you compare this with the EMPA-REG, CV death 38%. This is for SGLT2 about which we are talking everything. Look at fatal and non-fatal MI. It is not statistically significant because this is not an anti-atherogenic drug, the SGLT2. Yes, it does reduce cardiovascular mortality, but look at the benefits here with the pioglitazone in pre-diabetics. Now, what are the effect of pioglitazone on CV risk biomarkers? Significant increase in HDL cholesterol, triglyceride is reduced. These are randomized clinical trials which have shown the anti-atherogenic and cardioprotective effects of pioglitazone. Proactive Chicago Periscope Iris. Proactive study was almost 2,500 patients. All those who had a myocardial infarction were given pioglitazone. There is a repeat infarct reduction by 28%, acute coronary syndrome 38%, repeat stroke 47% reduction, and again fatal non-fatal MI 28%. But look at this study. This was using a statin for 6 years, and after using statin for 6 years, there is a 25% reduction, relative risk reduction. But look at 3 years, there is no change. But pioglitazone at 3 years gives you a 19% risk reduction. So recurrent fatal, non-fatal MI 28%, acute coronary syndrome 37%, secondary stroke 47%, but there was an increased incidence of heart failure. But the beauty here is those who even had increased incidence, the mortality was not increased, and the long-term mortality, it was less than all the other patients. Lesson from Chicago and Periscope. This is to show that the progression of atherosclerosis can be reduced. This is the Chicago study. They looked at the carotid intima media thickness. With glimepiride over a period of 72 weeks, it increases. With a pioglitazone, it decreases. These are other studies. And this is the study done by Steve Nissen, Periscope study using pioglitazone and glimepiride, where they looked at the atheroma volume by intravascular ultrasound of the coronary arteries, and again followed up after 18 months. And here with glimepiride, the atheroma volume has increased, but with pioglitazone, it has come down, suggesting that this molecule has a definite anti-atherogenic property. Now, this is a very interesting study, European multi-database cohort study done by Helen et al. You know, these were patients who had been on PIO and not been on PIO. 31,000 patients, both identical age group, patient years, everything is same. Look at this is all-cause mortality. You look at mortality rate per 10,000 years. In the pioglitazone group, it is 85 per 10,000 patient years. It is 250 years. That means 3 times more in patients who did not have pioglitazone. Similarly, for non-cardiovascular, same, 3 times more. All-cause mortality, 3 times more. And here, if you look at the cardiovascular cause-specific death, myocardial infarction per 10,000 patient years is 57,164. Again, 3 times more in non-pioglitazone. Stroke is again 3 times. Heart failure. Pioglitazone is supposed to cause heart failure, but look at this. This is 5.81 and this is 15. Those patients not given pioglitazone had a 3 times greater chance of getting a heart failure, arrhythmia, renal and all these things. So this analysis suggests that pioglitazone is associated with a decrease in both cardiovascular and non-cardiovascular mortality. These are the benefits which are seen with pioglitazone across the board, including NASH and hepatocellular carcinoma. So these are the favorable things: reduces insulin resistance, preserves beta cells, durable glucose control, improves lipids, anti-inflammatory, and so on. The unfavorable is the weight gain, congestive heart failure, bone fracture. Bone fracture is seen in postmenopausal females. Be careful when you use there. Now, weight gain. See, this is a MRI study which shown that given pioglitazone, the subcutaneous fat increases by 42%, but the visceral fat decreases by 25%. And that visceral fat is the pathological fat. That is the one which is causing all the problems. And this is where the benefit comes. So even if there is a weight gain in patients with on pioglitazone, that weight gain is cosmetic and it is not pathological. Pioglitazone and bladder cancer, a lot of studies have shown that bladder cancer is now gone. This study shows no evidence of association between ever use of pioglitazone and bladder cancer risk. There is a beautiful commentary by Robert Ryder and Ralph DiFranzo that pioglitazone is inexpensive because it has gone off patent now. Very effective at reducing HbA1c, no evidence of bladder cancer, plenty of evidence of cardiovascular benefit. So there is a case for early use of pioglitazone in our patients. We Indians are insulin resistant. Macrovascular damage starts many years before the onset of diabetes. Insulin resistance and its complication and beta cell preservation have to be adequately addressed for any positive long-term outcome. If insulin resistance is treated right from day one, you will see lesser and lesser macrovascular complication. You will not have a 45-year-old going for a bypass or an angioplasty. You will not have somebody getting a fatty liver and NASH and going to cirrhosis and hepatocellular carcinoma. So metformin and pio, most durable, less weight gain with metformin in place. Now, if to this you can add an SGLT2, the weight gain part, the fluid retention part, everything is taken care of, and that could become an unbeatable combination. Pio and Met gives you best results when endogenous insulin is present. So the take-home message would be a metformin Pio plus minus SGLT2 with when endogenous insulin is present. Early use is the most intelligent use. Now let me, since this everybody is talking of COVID, I thought I must add a few slides on COVID, pioglitazone and COVID. See, basically, whenever we talk of COVID, we say when comorbid conditions are there, the outcome is bad. And those comorbid are hypertension, diabetes, cardiovascular, and renal disease. And what these conditions have in common is a latent chronic inflammatory state. And they may be associated with alteration of laboratory parameters. Now, we know for a fact that insulin resistance amplifies inflammation. It is associated with several cardiovascular risk factors, and it is associated with increase in C-reactive protein, interleukin-6, TNF-alpha, and so on. All the inflammatory markers produces a procoagulant state with increased fibrinogen and PAI1. All these raises many concerns regarding the ability of patients with type 2 diabetes to respond. And this is why patients with comorbid conditions are at a greater risk for mortality. In diabetics, in type 2 diabetics, all these inflammatory markers are unfortunately increased. The anti-atherogenic adiponectin is decreased. Now, in severe COVID, C-reactive protein, IL-6, D-dimer, ferritin, lactic dehydrogenase, everything is increased. Such increases have been seen to be predictive of adverse outcome. Now, if we can prevent that, this is what a PPAR gamma activation does. You have an immune response and you have the cytokine storm, lung epithelial cell, endothelial cell, macrophages. PPAR gamma acts upon the transcription and upstream inflammatory genes, thus preventing the cytokine overproduction and could probably have a better role. Now, if you look at the benefits of PPAR activation, the direct benefit, reduced cytokines, reduced chemokines, reduced addition molecules. This is what is the main crux in COVID. Patients have a cytokine storm, and that is what leads to all the problems. Probably, if these patients are on a glitazone early, maybe they could, because glitazones take time to act. You can't start today and expect the benefits of glitazone to come your way immediately. So I think Shashank and others should look at doing a study in diabetic patients to see those who are on a pioglitazone prior to getting COVID and those who are not, and comparing the outcomes. And I'm sure you would have some very interesting data coming out from this. I think that should be it. Thank you very much, ladies and gentlemen. I have somehow managed to finish it in time.
Thank you, sir. I think there are no questions.
Panikar.
Yeah.
This is Dr. Jadhav.
Yes, yes.
I want to ask you whether sustained release or normal pios will help, pioglitazones will help, and what should be the dosage?
There is no sustained release preparation of pioglitazone.
Yeah.
Pioglitazone doesn't need a sustained release preparation. It's a one.
That's what most of them are using that.
No, there is no preparation available which is sustained release.
No, there are SR.
No, it's a metformin component in that which is SR.
Achha.
The pioglitazone is not SR. There is no rationale for an SR pioglitazone.
What about the doses, sir?
We typically use 15 milligrams, but in a fatty liver or in a non-alcoholic fatty liver disease, we go up to 30 milligrams. Means across the board, I use 30 milligrams if he has a NASH or a fatty liver. Otherwise, 15 milligrams.
Thank you.
Okay, Bhavik, take over.
Yes, sir, sure.
Thank you very much.
Thank you, sir. Thank you, sir, Panika, sir.
Thank you.
So for the next talk, we have Dr. Kalpana Mehta. She'll be talking about COVID-19 and the kidney, our experience of 465 COVID positive patients at Nair Hospital, Mumbai. For this, I would like to call upon Dr. Devdatta Chafekar. He's a senior nephrologist based out of Nasik, editor-in-chief of JMAP Journal, senior member of MAP, numerous publications in national and international journals, and national level faculty speaker. On to you, Chafekar, sir.
Thank you very much. And first of all, congratulations, Dr. Amit and his team for putting this all together. And it was a very nice and interesting scientific program. It's my pleasure to introduce Dr. Kalpana Mehta, who has been a very senior faculty member in the nephrology community in India. At present, she is the head of the Department of Nephrology at Nair Hospital, Mumbai. And she is a senior postgraduate teacher, also an examiner in nephrology. She has got a vast experience in both renal medicine as well as transplantation. And all of you know that Nair Hospital is was a COVID dedicated hospital. So I'm sure that the number of patients which Nair Hospital has seen and which Dr. Mehta must have managed, the number of patients is very high, and there is a wealth of information which we would like to know from her. The literature about renal involvement in COVID is very, very sparse. So therefore, this particular information by Dr. Mehta will go a long way in our understanding of what happens to COVID-19 and the kidneys. And I'm sure that this will also lead to multiple interesting publications, which we'll be able to see in the future. Over to you, Dr. Mehta.
Dr. Mehta, madam.
Yeah. I'm sharing my slides. Are my slides visible?
Yes, ma'am.
Yeah. Good afternoon, everybody. And first, on the outset, thank you for giving me the opportunity to be with you all and sharing our experience at Nair Hospital, which I'm trying to, with so much of pathophysiology, symptoms, treatment, what's new has already been spoken about COVID-19. I will restrict myself to our experience at Nair Hospital in the last over 7 months. Now, as Dr. Shashank Joshi has said that Maharashtra is on the global map as of by 23rd October, and Mumbai having the case fatality ratio of 4% with death around 10,000. During this period, from last 6.5 months, the Nair has seen around almost 8,500 COVID positive patients. This does not include the suspect patients in this. Now, this is as of you all must have read yesterday that around 10,000 deaths in Mumbai, and the most important factor is late detection. I would say the late reporting rather than late detection, that is by our patients. Now, talking about our experience, our journey started from Kasturba Hospital. All of you know that this is MCGM's main infectious hospital with a molecular lab there. And we started attending this. The COVID was in this area with March 2020 onwards, 12th March. Our residents and faculty used to take daily rounds there. The numbers were not high at that time. Of course, the first dialysis patient came. There was no dialysis facilities there, and we had to set up the dialysis facilities there, which we did along with KEM by using our HD machines and our RO plants portable from KEM hospital. And the dialysis was managed by technicians from KEM, Nair and Sion in 3 rotations. Now, during this time till we became COVID positive dedicated hospital, we were managing only suspect patients on the first floor of our hospital building. All positive were shifted to Kasturba Hospital, while the non-COVID was done in our main AKD. But came 18th April and we were told to be a dedicated COVID hospital. And at this time, 2 of our residents tested positive. And we were all allowed only 72 days for testing and were asked to join back immediately to start the services. Hospital made almost 1,043 beds available for COVID positive. These are just a nutshell giving the important building. This is our hospital building, this is our O building, and this is mainly our administrative building, that is a college building. And our COVID OPD runs here, which is made during this last 7 months. Now, the main group, which was biggest challenge, was the CKD-5D, that is dialysis dependent group in early period. And you know, Mumbai has almost 10,000 patients who are on maintenance hemodialysis. The reason why this was the biggest challenge was there was fear everywhere. Doctor, patient, other healthcare workers, there was lockdown, which was making difficult travel. Buildings were shut down because centers were detected positive. Absenteeism was a major problem. And this time, the patients were without HD for almost 7 to 15 days. And as I said that I have not seen such high values of creatinine in these patients. Some of them were so sick and we had no vacancies. They literally put on their mats and said, we will wait here till you give us a vacancy. And literally touching the feet of our residents in OPD. So that was a bad situation in the very early period. Now, being a COVID hospital, then we set it up in the 3 different areas. The main, our area, which was main AKD, took stable COVID patients. We had 7 dialysis stations there, which running in 3 shifts. In H building, we set up 2 more areas. One for COVID unstable patients, which are hemodynamically unstable or on ventilator. There were 2 HD stations, again in 3 shifts, and 1 area for suspects with 1 HD machines. So we could start with 3 areas with 30 dialysis sessions per day. So almost 27 positive patients and 3 suspects could be dialyzed in 1 day. Now, this is our SketchUp of our normal AKD. Normally, we enter from here, and this is our main entrance of AKD. And from here, this is our negative area. And this is a positive dialysis patient area. Now, for COVID, we closed down this entrance. Patients entered from here, went in here, got dialyzed, and went out from there. While the staff entered, changed into their scrubs, and then changed in this area in donning, saw the patients after being done, came out from doffing in their scrubs and that. This is how we managed in the main AKD, which handled almost 7 patients, that is 21 patients daily. Now, in the beginning and still now, our AKD ICU is not negative suction. So our windows used to be open, and that is how we, in the early periods, we managed. Now, this is my experience in the early period, that is till 31st August 2020. By this time, we had almost 465 patients, with the hospital having total admissions of 7,400 by that time. That made the nephrology references almost about 6.29%, of which the dialysis dependent patients, which are CKD-5D, were 302. AKI together was around 154, where there is AKI mainly 131 and AKI on CKD 23. Transplant group was smaller, and these were all not our own transplant. The moment our own transplant knew that we are COVID positive, they stayed away from us. So the COVID dialysis during this period, as I said, with 3 shifts in a day, and the maximum number of COVID positive patients we had at one time was 54, and 27 were the maximum sessions done in 1 day. As explained, we have separate entry and exit points for the patients. And we used dialyzer singly. There was no reuse even till today. Regular heparin was given in all patients. All oxygens were given 5,000 IU heparin BD. Thrice a week dialysis was given in all patients except in the first 2 weeks when there was a massive workload. All patients with surgical mask compulsorily. Healthcare workers obviously in PPE. AKD surfaces, including machine surfaces, are clean even today in every shift with 1% sodium hypochlorite, and machine is given hot chemical disinfection after every shift. Now, can I talk about medical management of antiviral and anti-inflammatory in the early period? No, because the changing and the dynamic guidelines during this period, pandemic scenario with a mismatch between the resources and the demand. Availability of the drug was a great problem in the early phases. If there's available, affordability was a problem. And if both were there, the indication and contraindications really came in the way. So in the early phase, our basic discharge policy was asymptomatic patients for COVID for 3 days. Of course, not biochemical parameters reasonably well maintained. And we were asking initially for 2 PCR negatives before discharging the patient. As has been said multiple times during these sessions earlier, once the kidney can be affected because of tubular injury, myoglobin cast nephropathy, thrombotic microangiopathy, collapsing coagulopathy, direct infection, apart from the multiple other factors causing prerenal factors. So given this scenario, when a CKD patient who is already having macro and microvascular disease with uremic cardiomyopathy, multi-system involvement, obviously we are looking at a serious disease. Now, just in a nutshell, the CKD 5D patients had about 302, 203 the outcome available, which we knew what happened to them, the remaining were still with us. The mortality was 22.63%. Definitely higher than non-COVID CKD population before COVID. 77% were discharged. Looking at AKI, out of this total population, mortality was 52% with 47% discharge, and transplant, we lost 3 out of those 9. The time taken for the PCR to become negative, it was 13 days on average in CKD, but some of them took 40 days also, while in transplant, some of them took 23 days also, but on average, it was 15. Now, coming to CKD 5D as a group, as I said, the mortalities were 22%, but what's important is that 1/4 of them, almost 25%, were asymptomatic population. And if you compare survivors and non-survivors, the important statistical factors which made difference between the two was higher age, presentation with fever, dyspnea, encephalopathy, diabetes as a comorbidity. These were the significant factors. Coming to the next group of AKI with COVID-19, we graded them as per Akin staging. Almost 67% were Akin 3 group, and 40% almost required dialysis in this group, while the 1 and 2 were 12% each. 65% of them had proteinuria, and hematuria was present in 41%. What was the recovery of the renal function in AKI? Complete in around 64%, partial in 32%, and there was no recovery in 2 patients. Now, these patients have been called for follow-up, and we'll see how they really do. Of these 2 of them, 1 of them have recovered completely. This was a earlier data. What about pathogenesis? Since, as Dr. Shashank Joshi also said, there is no histopathological diagnosis, as we have no PMs and no kidney biopsies. Yes, positive findings of proteinuria 65% and hematuria 41%. 7% had positive blood cultures and 4 had obstructive uropathy and stenting done in 3. Multifactorial elements, including pre-renal and dehydration, were also noted in many patients. So if you look at the AKI group with COVID-19, these are the multiple factors, clinical demographic, where we try to compare between survivors and non-survivors. I will focus only on the significant factors. Was that non-survivors had presented with breathlessness, which was statistically significant. They were all
I think Kalpana, you've been not audible. is stuck. Dr. Kalpana?
Madam, we lost your audio.
We have lost your, probably her signals are weak, Amit.
Right.
Yeah. Can you ask somebody to check with her?
Bhavik, can you just coordinate, please?
Yeah, she's back. She's back.
Yes, sure.
Kalpana is back.
Yeah, ma'am, we
there was
had
some
lost you.
connectivity challenge, Kalpana.
So I'll have to share again, right?
Yeah, you have to share again.
Yeah. So, yeah. So other factors which made it discriminate are ARDS. If you really look at it, there was no patient in non-survivors where there was no ARDS. And if you, so almost you have 77% patients were with the severe ARDS. Oxygen need made an important difference, almost statistically significant. There was no patient who did not need oxygen in non-survivors, and none of the survivors needed invasive ventilation. Coming to inflammatory markers, the important inflammatory markers in AKI which made difference were ESR, which was 80%, this ESR, CRP, these are the values, and LDH. And second one was interleukin 6. Treatment-wise, again, this was the early period. But if you look at it, AKI got almost all, 97% received steroids, 81% received anticoagulation. Tocilizumab and remdesivir, as per availability then, was in around 13% to 10% respectively. This is a small group of transplant, but I would still like to talk about it. That AKI was seen in 4%, in 4 out of these 9. And if you see the first top 3 patients, all of them were in ARDS and having more than 30% involvement on CT scan. All of them received tocilizumab and all of them succumbed. Now, all patients we had stopped MMF, and tacrolimus was reduced or stopped in severe cases in all these 9 patients. Look at the last 3 groups where there was no oxygen needed and all of them have recovered. In fact, one of them was managed with home quarantine. Now, looking at these middle 3 groups, this person in those had the IL-6 levels to the tune of these first 3, and even CT scan 50 to 60% still recovered completely. Right? While the person, in spite of normal IL-6 and not severe CT scan levels, had died. Of course, so these, of course, highlights the important facts, the reporting the patient early, and patient's innate immunity and his own immunity also matters a lot. In these patients, all 5 survivors reached home. I mean, they were discharged with a normal creatinine. What are the problems faced by us during this period? Severe manpower problem to set up from our 12 dialysis machines to all so many areas handling we had to recruit new technicians, almost 7 new technicians we recruited. PPE and N95 availability was a big problem. Hot April, May and PP, we all know. We still don't have negative suction AC. Equipments, generous donations and MCGM, we are now enriched by almost 5 portable ROs and 7 new dialysis machines running continuously, whether it is RO or dialysis machine, gave a frequent breakdowns. And I really salute all those engineers who really came in PPS very often, at times twice in a week, to repair these machines. Availability of consumables and spare parts during lockdown is a big issue. In the early period, patients were complaining of late discharge because we used to keep them for 2 negative swabs. But later on, when they were sent early, they were refused by the primary center. So they started complaining about early discharge also. All of you must have heard about the Project Victory, because to handle those patients which are running from one hospital to another to get the bed for dialysis, as they were said no by the primary unit. This was the setup by Project Victory by MCGM, where it has a coordinator at the central level, and in each hospital had their own coordinator. And we used to upload our patients on this Project Victory, and the patients were given the bed and informed accordingly. And this was of a great help, which was started on 14th May 2020. Must say that Seven Hill Hospital was under our care for that time, and our NAIR lecturer at that time handled additional 320 patients till 31st August. Now it is being looked after by the KEM Hospital now from end of last month.
Ma'am, 5 minutes left.
Yeah, this is our 5 minutes.
Yes,
Hello?
ma'am. 5 minutes. Yes,
Yeah,
ma'am.
I'll finish in 2 minutes. Now, this is our teamwork, which is usually seen. These are our faculties, and these are our teams which work in 3 shifts. Now, right now, we are a hybrid now. We have made this as a non-COVID building and this being the COVID building. So what would I say with our experience? Yes, kidney involvement is a serious disease. CKD 5D with COVID-19 is around 22%. Mortality in AKI is around 52%. In kidney transplant, it was 33% in our group. Complete recovery of renal function was seen in 64%. And all 5 survivors in transplant group at discharge had reached baseline serum creatinine. And the important significant factors were higher age, diabetes, dyspnea, ARDS, edema, oliguria, encephalopathy, inotrope support, invasive ventilation, and higher inflammatory markers. Now, this was my experience, our experience till August 20 end. Now, by 30th September, the total number has gone to 805 with AKI being 286. Now, we will try to compare this second half group with the first half group and see what the difference has made with remdesivir and tocilizumab available to us. Have we used remdesivir? Yes. In CKD patients, around 26, and complete recovery of renal function was seen in 9. Mortality 13 is, of course, because of multiple factors. Our present discharge policy is same, except that we usually send the patient home if negative on 8th day. But if it is not negative on 8th day, we repeat on 14th day, and irrespective of the report, patient goes home at this time. Now, we have made our own remdesivir policy after going through 7 months of this. So those patients who are on oxygen are given remdesivir even with renal failure, and GFR more than 30 ml and on dialysis are given the normal dose, and in others we usually give it on alternate day after giving the first dose, and written and informed consent, and the monitoring is done. Okay, so that's it. Thanks, happy Dashera, and stay safe.
I have a question for Kalpana. If
Sure, sir. Sure.
Kalpana Mangesh here. Hi, happy Dashera.
Yeah.
So nice to see you after a long time.
Yes.
Just wanted to know
Yes.
very quick, what was the use of erythropoietin in all these patients, those who have been there on the parallel line of management, and was there any impact on the outcomes as far as mortality?
Actually, usually these patients, first of all, are not our own patients. They are all CKD patients because Nair Hospital as such do not have any dialysis policy permanent. Now, all these patients usually our hemoglobins are never high. They're usually poor patients who are usually around in the range of 9 to 10. But EPO was continued in all, and we did not find any adverse event in that.
But then was the mortality which was there in especially very high in AKI patients rather than stable CKDs, those who are on with dialysis?
Yes.
Could be, is it that the acute presentation or probably a precipitating factor which was contributing to it, or it was something else?
If you really see the overall literature worldwide also, the AKI mortality is really high in the range of going from 40 to 60%. Now, if you look at these patients, most of them, if you have reached for AKI, were on oxygen, and most of them have died within the first 24 hours to 48 hours. So the first main factor, I would say, it is reporting late and in a severe condition. And of course, the factor which makes a difference is also their own immune status and immune makeup. Yes, now we'll need to see this AKI group in the second half when the remdesivir and tocilizumab and early reporting and awareness has made any difference. We are analyzing that. As I spoke to my other group, they said there is a difference, but I wouldn't say it has gone down from 55 to 60%. It has come to as low as 5%, definitely.
Yeah, thank you, Dr. Kalpana, for that extensive review of your experience. And I'm sure that this will go a long way in our understanding. I have 2 questions for you. What was your heparin policy as far as heparin administration is concerned? Because what we have done at our center is that we don't use low molecular weight heparin. We use the regular heparin because we find that if there is a bleeding incidence, which was there significant in many patients, it can be reversed very, very easily. So that is the first question regarding heparin. What was your heparin policy? And the second question is that when you started using remdesivir in these patients, Did it, and if it was used early in your CKD patients, did it make a huge difference as far as outcome was concerned?
Now, coming to heparin, we also have used unfractionated heparin. We have not used the low molecular weight heparin. And we use the regular heparin in all patients on dialysis. And in fact, those who are on oxygen also received 5,000 heparins BD in their wards respective. Initially, when they were on heparin, we decided to stop their heparin in AKD, but then we had just 1 or 2 dialyzer clotting. So we continued the heparin in spite of their heparin in the ward. So our dialyzer clotting was not really very high. It was not high at all. In fact, we had only 1 or 2 incidents of fistula blocks. Coming to remdesivir, yes, as I said, it has made difference when it started early. In fact, not waiting for the patient to go for mechanical ventilation. Of course, how the remdesivir is coming to us, it's usually coming from MCGM in batches whenever the tenders is ready. And some of the patients who afford it. Now, it should be started immediately as soon as the patient is on oxygen rather than really waiting for the patient deteriorating. So it is making a difference, but yes, I wouldn't be able to tell you in terms of figures how much difference it does make. As I said, the number has gone from 465 to 800. We'll analyze the next 400 and we will know the answer. So I would say one should start it early and not wait for really patient going on cannulas and mechanical ventilation. Whether if it is on less than 94 and it requires even 2 liters oxygen, I would suggest it's make because we are recently seeing the difference being made to them.
Yeah, and one last question regarding
tocilizumab we also not seem to be working, Kalpana, in your state of the patients. Toci is not making any difference, probably.
Yes. Tocilizumab is also not, if you see those patients at tocilizumab levels of 5,000 and 10,000, again, as I said, that Dr. Shashank Joshi was discussing, every patient comes with its own set of, comorbidity, time of presentation, its own disposition as far as the immunity is concerned, right? So that is really very important.
One question in transplants, I think you have, of course, as per the recommendations, you stop the MMF and the TAC. And the CNS.
Not always.
And,
not always. No, TAC was not stopped always. Only when the patient was severe, we reduced the dose of TAC. But if there's no major difference, then we omitted that.
Yeah, I went through your chart. And I think the last 2 patients, the TAC was continued and the others, the TAC was stopped. Yes. Now, the question here is that what is the incidence of graft dysfunction as far as these patients are concerned after we stopped the immunosuppression? And then what was the recovery of the graft function after it was reintroduced?
Out of these 9 patients, now all these patients were with us till they were discharged or they expired, right? So out of this 9 patients, 5 went home back with normal creatinine. And out of 9, 4 had AKI. And one of them was, in fact, it was a TAC toxicity. It was not even, in fact, we had to reduce the TAC dose. TAC level was somewhere 8 point or something. We had to reduce it and he recovered completely, though he had a baseline chronic allograft nephropathy.
Yeah, and just one comment on Dr. Tivarskar's question regarding erythropoietin.
Yes, sir.
What we have seen is that if the patient is on a large dose of erythropoietin, large dose by I mean we say more than 10,000 units per week, that is definitely prothrombotic.
Yes.
However, if the patient is on a lower dose, then I think it can be continued. That is
what our experience my question was in regards to the same, sir, as you rightly pointed out.
Yes,
and also a little skeptical about,
What I would just comment on that, Dr. Mangesh, is that
yes.
I don't believe in giving 10,000 as a single dose to this patient, right? I don't believe in that. And hence all our patients are usually will not be on such high dose or 10,000. They're ideally 2,000 and maximum patients are 4,000 BD. 10,000 a single dose, I don't believe in.
Yeah, and Kalpana, those TAC patients, those who also have they received TOSI in your group? Those
yes,
who are on with TAC also?
If you see that the chart, the first 3 patients have received tocilizumab.
Very interesting.
If there are no more questions, I think we should thank Dr. Kalpana Mehta for her excellent presentation. And we wish that your experience converts into publications for all of us. Thank you very much.
Our paper has been accepted by Indian Journal of Nephrology. Probably you'll see it in next month.
Thank you.
Thank you so much, madam. Thank you, Zafikar, sir. I would ask Bhavik to please take it forwards.
Yes, sir. So for the next talk, we have Dr. Rajiv Soman, who is going to be talking about interesting cases of COVID-19. For this, I would like to call upon Dr. Ullas Kondapale, sir. He's a senior physician based out of Aurangabad, the organizing secretary of MAPCON 2018, and he's a treasurer of MAP. Sir, please carry on.
Thank you very much. Glad to see you all. And hello.
Yes,
can you hear me?
Yes,
yeah.
sir.
Yeah. Glad to see you here. For this one, I am glad to introduce Dr. Rajiv, sir, who is a senior most person, and he is a specialist in infectious diseases. He is presently in Hinduja Hospital and also in Jupiter Hospital, Pune. He is a senior postgraduate teacher in infectious diseases and also been a huge experience into all these things. He has multiple publications as far as national and international publications are done. With his experience and some interesting cases that he had seen during this course, over to him for next presentations. Thank
you. With your permission, I'll start my screen share.
Yes, sir.
It's really a great pleasure. I am delighted to be a part of this excellent program. I've been listening to it whole morning, and
we can hear you, sir.
You can hear me, okay. I'll just go to this. Okay, so I thought I'll put together a few cases, and more than interesting cases, I think there are some messages which emerge from these cases. So let's take the first case of post-COVID-19 sepsis. And by this, I don't really mean the acute viral sepsis, but after SARS-CoV-2 has had a rampage in the human body, and then we are left picking up the pieces, what really happens. So this is an elderly gentleman with fever, cough, and who was seriously ill, collapsed, and was brought and intubated in the emergency room. Can I switch this? Yeah. And the X-ray, as you can see, did show the non-specific abnormality. The RT-PCR was positive, oxygen requirement worsened, and the patient actually received everything. So dexamethasone, remdesivir, as well as tocilizumab. There was gradual improvement, but 7 days later, there was a recurrence of his fever, worsening oxygen status, purulent secretions, and a rise in WBC and the PCT. So obviously, there was some suspicion of ventilator-associated pneumonia, and a tracheal aspirate as well as a blood culture was sent, along with serum beta-D-glucan and galactomannan. Now, this patient, remember, has received tocilizumab, and so briefly, which are the infections which could occur after that? So you have a lot of bacterial infections, a lot of these fungal infections, as well as late, you can have even TB as well as other infections. You must remember here that immunosuppression may continue for a long time, even after tocilizumab has been stopped. So with this in mind, empiric meropenem was started. So the tracheal aspirate secretion was showing a lot of pus cells. It showed a lot of cocobacilli on smear, and it surely grew Acinetobacter baumannii, as is quite common in many of our ICUs, with a colony count of greater than 10⁵. So now how do we proceed further? So the next question is, what in the minds of the physician are empiric pathogen thresholds? So if you have a mild illness, then you want your empiric therapy to be working at least 80% of the times. But if the patient is seriously ill, it could be as higher as 90 or more. And these would be considered as empiric physician accepted thresholds. So now let's look at the epidemiology. And this is coming from the GLASS network, which was collaborating centers across India. So there are many centers which participated in that. And this shows you the lowest and the highest susceptibility of Acinetobacter baumannii to various drugs. So if you look at it, and if you look at these physician accepted thresholds of 80 and 90%, we want a drug which is going to be working at least 80%, preferably above 90%. And the only drug which you can see here is colistin or polymyxin. We also need to know a little bit more of what is the type of resistance which occurs in each of these bugs, as well as what is the mechanism of resistance. So I will not go into the Enterobacterialis, the E. coli, Klebsiella, but confine my remarks only to Acinetobacter because that's the organism which we have here. So this organism is going to produce ESBL in more than 70%. And see, the type of ESBLs are also different with Acinetobacter as compared to the CTXM 15 and so on, which we see with Klebsiella and E. coli. Carbapenem resistance is again to the tune of 70%. And this is the mechanism by which it becomes carbapenem resistant. So most of the time it is OXA, but it's not OXA 48. It's OXA 23, 24, 51, and 58. And there is a small number which might also be colistin resistant, which could be at something like 3.5%. So with this in mind, obviously we need to change. Once the Acinetobacter in a seriously ill patient, you have to change to something else. And that was a polymyxin B. And sure enough, we got the susceptibility data. We showed that it is susceptible only to colistin and tigecycline. And the colistin susceptibility was checked with the broth microdilution, which is the preferred method of testing susceptibility. So the question in front of us now is what should be used for treatment? Should it be polymyxin or colistin, one of them? Or should it be polymyxin plus nebulized colistin plus meropenem? Or should it be ceftazidime, maybe Bactam plus aztreonam? Or should polymyxin plus nebulized colistin plus either tigecycline or minocycline? And if you look at this, the meropenem MIC is greater than 16 over here. So if you use only one of them, such as either polymyxin or colistin, we know that there is penetration into the lung and into the epithelial lining fluid. And that's the reason why poor results in experimental models of both HAP and VAP have been shown with use of only the polymyxins. So what can we add to that? Should we add meropenem? Is colistin monotherapy better than colistin plus meropenem for Acinetobacter? And the answer is yes. So if we have a belief that meropenem should be added, it may not be beneficial, but at least it cannot do any harm. That is also not a correct interpretation of the data. And adding meropenem can sometimes lead to changes in gene expression, and it may lead to, which is induced by the carbapenem, and that leads to restoration of its and virulence. So in Acinetobacter, when meropenem MIC is more than 16, there is absolutely no reason to add meropenem to the polymyxin. In fact, we should not add because it might produce detrimental effect. What about this new kid on the block, the ceftazidime avibactam plus aztreonam? Remember here that Acinetobacter produces oxas, which are these, not 48, and all of them destroy avibactam. And therefore, now there is a problem. Since avibactam is not going to be effective, neither ceftazidime nor aztreonam will be effective against this. So they will not be protected from the ESBLs which Acinetobacter produce, or from the MC which it also produces. So really the drug of choice or the combination of choice here is going to be polymyxin plus systemically plus nebulized colistin plus either tigecycline or minocycline, whichever shows good susceptibility. And here I might mention that minocycline probably has better lung penetration and might be preferred if it is found to be susceptible. I'll briefly show you these organisms which we found in post-COVID sepsis. And what did we find? We found ESBLs producing E. coli. We found E. coli which were carbapenem resistant. We found Klebsiella which were also carbapenem resistant. We found Serratia. We found carbapenem resistant Pseudomonas aeruginosa as well as Acinetobacter baumannii. Additionally, we found Enterobacter, Serratia, Stenotrophomonas. We also found some rare organisms such as Chrysiobacterium, and the reason for that is probably the infection control problems which we have, and Stenotrophomonas. So both Candida auris as well as Candida glabrata were also seen. So now if you look at all these organisms, the E. coli, Enterobacter, Klebsiella, Serratia, and Candida glabrata probably could be endogenous. Okay, so maybe they are coming from the patient's own microbiota. But we must remember here that Pseudomonas aeruginosa, Acinetobacter, Elizabeth kingia, Stenotrophomonas, Preziobacterium, and Candida auris are environmental. They are not part of normal human microbiota. Okay, so that is the problem here. Also, interestingly, we saw no case of Staph aureus pneumonia or even CRBSI, and we saw no case of strep pneumonia producing pneumonia. So why is this important? Because strep pneumonia was one of the most important killers in the old Spanish flu. And we also know that it occurs in patients who have had influenza and so on. However, we did find that these are not there. And therefore, the pernicious habit of adding, say, maybe teicoplanin or vancomycin or linezolid as empirical therapy probably is called into question. How do we fashion empiric therapy? It is really difficult because it is so difficult that the organism which you are going to encounter might be resistant to what we might choose as empirical therapy. So if you have chosen meropenem, there is a problem because carbapenem resistant enterobacterialis may be there. If you have chosen Cas-Avi plus Aztreonam, it might be a problem because it's not going to work for the Acinetobacter. If you have chosen even polymyxin or colistin, there is again a problem because you might encounter Serratia, the cold area. Again, these are waterborne organisms and again likely to come up in people who may be dialyzed or maybe in the ICU and receiving a lot of nebulization or something like that. There is a problem because Elizabeth kingia is a gram-negative organism, but its susceptibility is like that of gram-positive organisms. Okay, so it is very important that the microbiologists use the appropriate gram-positive card for knowing the susceptibility of this organism. And if you are using fluconazole, a problem because what we encountered here was Candida glabrata and Candida auris. Both of them are likely to be resistant to fluconazole. So what messages are coming from this case? We definitely need meticulous infection control practices. This is, of course, more easily said than done. We have a problem of nursing ratios. We have a problem of working with the PTs and so on. And therefore, it's really, really difficult to have good infection control practices here. The clinician must anticipate secondary infection, but at the same time, he must rule out colonization. Everything that is cultured will need to be interpreted, whether it is a colonizer or whether it's a true infection. Probably it makes sense to avoid the most potent antibiotics prophylactically because the vast majority may not develop infection and may not really need it. But we need to know detailed local epidemiology of the organisms and not just the names of the organisms, mechanisms of resistance is also very, very important. With all these, we may then fashion appropriate therapy. And the remark that I would also like to make is, although antiviral therapy such as remdesivir has not been shown to directly impact mortality, I'll submit to you friends that this definitely leads to reduced length of stay. So it reduced length of stay on the ventilator, reduced length of stay on having the central line or being in the ICU can probably impact this kind of a post-COVID symptoms. Let's move to the next case. And the question is whether it's COVID-19 or not. So this is a 2-year-old lady who has rheumatoid arthritis MCTD on methotrexate and hydroxychloroquine. She had mild fever and body ache and dyspnea for about 20 days, which worsened markedly over the last 2 days. Her saturation on room air was 68%. Her granddaughter had sore throat and fever 20 days ago, which had lasted for a few days. Now, all the family members were locked down in this particular household for the last 4 months, except her son, who is a cardiac surgeon, and her daughter-in-law, who is a dental surgeon. So she was desaturating on room air, and this is her X-ray, which was on. So it does show a lot of non-specific fluffy shadows, especially in the lower zones. And the HRT of the test was also done, and this was the report by the radiologist. So there is finding fair amount of ground glassing, is finding lymphadenopathy, is finding some septal thickening and crazy paving and so on. And at the end of it is saying that this is suggestive or consistent with COVID-19 infection. And this is what I'll show you. These were the plates of the HRCT. So you see a lot of these features. Look at it carefully. You see a lot of fibrotic markings even in the upper zones as well as in lower. And you are seeing some steps or small cystic appearances in parts of the lung here, here, over here, and so on. So with this, we were like, what is this? Is this the rheumatoid arthritis lung? Is this COVID-19? Is it both A and B or none of the above? And let's discuss each one of them. Rheumatoid lung, possible. We saw that this lady has a long-standing rheumatoid. You saw her fingers, how deformed they are, and so on. So she has significant RA. There is this subacute respiratory involvement. The upper zones are involved. There are small cystic areas as I described. There are upper zone fibrous bands and there's some lymphadenopathy. So all these seem to be in favor of rheumatoid lung. On the other hand, could it be COVID-19? There is this epidemiologic context. This case was seen in July when there were a lot of cases there. There were patchy ground glass appearances as well as crazy paving. But look at this pattern. There has been worsening of her oxygen status 20 days after the onset. So that is a little bit unusual. Most of the time, I think Shashank alluded to this point, that most of the time the patients, if they are going to worsen, they will worsen around 10-day time. And we found here that upper zones are equally involved as lower zones, which is not really fitting in perfectly with COVID-19. Could it be something else? Could it be pneumocystis pneumonia? We may need to consider this in an immunocompromised patient. I remind you that she was on methotrexate and steroids. But what is the pattern there? Generally, there you will see hilar ground glassing as well as a high beta-D glucan, which will be seen here. But subpleural fibrosis and bands are very, very unusual with PCP. So A and B together seems to be the appropriate working diagnosis. Now her RT-PCR came negative from the nasopharyngeal swab. A little of information seen here. The beta-D glucan was 124, whereas generally what we see in PCP is more than 530. Now remdesivir as well as steroids were started. And remember here that you don't need really to have a RT-PCR positive for starting remdesivir in suspected patients. So these were started at that time and dramatic improvement followed within 2 days. I would sustain that is unusual with COVID-19. So a repeat NP swab was done, even that was negative. So now by that time, this patient's illness was around 23 days and we did a SARS-CoV-2 antibody. And on day 3, that was negative, thus really ruling out COVID-19. So what messages are emerging is diagnosis is not always easy. You can have overlap with many other diseases. You need to design radiologic diagnosis because after all, the radiologist is only shown the images and not really the patient. So as a physician or as an infectious disease physician, you really need to look at everything properly. So check pattern. Also pay attention to what fits and what does not fit. So there were several things here which were telling you that there is chronicity in this lung. There were small blebs or fibrosis which was there. So the cause as well as the time course of clinical response needs to be carefully evaluated. You need to interpret the RT-PCR. We know for certain that the sensitivity of RT-PCR is at best only 70%, and that's the analytical sensitivity of the test. In actual practice, when you do it, clinical sensitivity is far lower. And what about the interpretation of antibodies? When do they become positive? They become positive after 15 days and definitely would be strongly positive in a patient who has had a severe illness. So as a physician, we need to carefully interpret all these tests. We need to interpret their positive predictive values as well as the negative predictive value. So when the test is done, when the antibody test is done, maybe after 3 weeks of rather severe illness, and if it turns out to be negative, it will really have an excellent negative predictive value, which tells you that this whole illness cannot be COVID-19.
So 5 minutes
finally,
left, please.
overlap of COVID-19 with many other diseases is something which is very important. And really, and in conclusion, I am going to end with some of these closing thoughts. So a high index of suspicion of infection needs to be maintained in the post-COVID state, especially in the ICU. But I'll even tell you that we have seen other patients who are not in the ICU also getting some infections. But at the same time, colonization as well as non-infectious causes need to be considered. And that's why I put up one non-infectious disease here. Clinical examination, I know there are a lot of problems with the PPE and so on, and therefore we cannot do a proper clinical examination like what an infectious disease physician would want to do. Doing CT scans, not always possible. Moving the patient to the CT suite is difficult. Infection control issues are there. Invasive procedures, again, are going to be very difficult, which we often want to do in the presence of pulmonary infections. Empiric antibiotic therapy should be used, and that is based on the syndrome, on the guidelines, and very importantly, on the local epidemiology. Okay, so understanding this kind of local epidemiology is very, very important. I can't emphasize how important it is. Based on that empiric therapy, you may sometimes have to escalate, but it's always important to pay attention to de-escalate and terminate therapy as soon as possible. Stewardship, antimicrobial stewardship should be promoted even in these challenging times. We must remember here that someday this pandemic is going to be over, and then when the dust finally settles down, what are we going to be handling? We are going to handle more and more antimicrobial resistance. The second case tells us that the manifestations of COVID-19 are really protean. Anything can be COVID-19. On the other hand, not everything is COVID-19. I'll leave you with this thought and lots of questions, more than what anyone else answered. I'll stop my screen share here and would be happy to take any questions.
Thank you, Dr. Kondapati.
With that, I'll turn back to the moderator and chairpersons. And again, I thank you once again for this excellent opportunity. I really enjoyed your whole program very much.
Thank you, Dr. Raju, for the received lecture that has been done. Any questions or any comments by the panelists?
We have not got any from the audience for this. I think sir was very clear and crisp in his presentation, so I thought it was completely taken care of.
I would like to say something.
Yes, sir. Yes, sir.
Very nice lecture. Obviously, as always, Dr. Raju Soman, this is Girish Rajadeksha here. I think when we had given tocilizumab, especially above the age of 70, we have seen this very frequently, that they improve as far as the respiratory distress is concerned, but later after 2 to 3 days, they go into severe sepsis and many of them died. So we had made a policy that anybody who's above 70 years of age, especially with diabetes and some other comorbidities, we will not give tocilizumab or itolizumab to these patients. So what is your experience about that?
Yes, Girish, I absolutely agree with you. This was a very early case. That time we didn't know anything about any of the drugs. Right. These were the 2-3 drugs available, so just throw them at the patient where we didn't really pay attention to so many of these factors. And today I can definitely tell you that yes, tocilizumab does produce a lot of problems. Even steroids do produce a lot of problems. The other thing which I didn't have that much time to show more cases, but recently we saw a case where the patient was receiving huge doses of steroids. See, although in trials they have used smaller doses and only for 10 days, I have seen in practice physicians using really large dose. And then we have seen pulmonary mucormycosis, and we have seen all sorts of infections coming up as post-COVID sepsis. Correct. So what you said is absolutely correct. In elderly patients, maybe the benefits do not outweigh the risks. We should be very, very really cautious in the use of immunosuppressive therapy for the elderly patients. And tocilizumab, see, there have been so many papers, and some of them have said that yes, although the incidence of infection after toci goes up almost to double, they can be managed. I can quote one paper called from Emily Sommers, and they say that yes, but we could manage almost all of them. But what is our epidemiology? Can we manage these carbapenem resistant bugs? Can we manage this kind of mucor and so many other things which would occur as a result of using these immunomodulators? So this is a question for all of us. We have to pay attention to our local epidemiology. It's not very easy as compared to in the Western countries. Our bugs are far, far more resistant.
Thank you, sir.
Kondappally, can you please wind up, please?
Thank you very much, sir. There was a question that I am seeing. What is the place of bronchoscopy in these things?
See, from an infectious disease point of view, bronchoscopy is an extremely valuable intervention, especially if you are dealing with immunocompromised patients. So, once you are in the post-COVID sepsis sort of phase, that is the time when bronchoscopy may be somewhat easier for the pulmonary physician. So if you want to remain friends with the pulmonary physician, we cannot advise bronchoscopy. Okay, but once the patient has gone through that phase and now he's left with some, say, post-COVID aspergillosis is what you are suspecting and so on. I'm sure your intention of asking that question is this. Maybe somebody gets nocardia, somebody gets aspergillosis. So how else are you going to make a diagnosis short of CT guided biopsy, VATS assisted biopsy, or better still is bronchoscopy? So certainly there is a role. I don't think there is a big role in the acute phase where it is not going to contribute much. In fact, it will place many people more at risk also. So the risk-benefit ratio may not be favorable in the acute phase, but later on, certainly it will be something which we have to look at. No great experience on carrying out this procedure, but no reason why it should not work. It will work.
Thank you very much, sir. Thanks for the things and guidelines that has been provided by your own expertizations. Over to Amit and everybody.
Thank you so much, sir. As usual, a pleasure to have listened from you. Thank you so much.
Thank you, everybody.
Thank you, sir. Bhavik, can you take it forward, please?
Yes, surely. So for the next talk, we have Dr. Swapnil Chakla. He's going to be speaking about role of ECMO in treating COVID-19. For this, I would like to call upon Dr. Rishikesh Joshi. He's the director of Joshi Clinic in Kothurud, Pune. He's a senior physician and a diabetologist based out of Pune. On to you, Joshi, sir.
Yeah, good afternoon, everyone. It's such a nice talk by Dr. Soman, sir. Without wasting much time, let me introduce today's speaker. Now, we have Dr. Swapnil Chakla, who is a consultant pulmonologist practicing at Nasik. He has done extensive work in COVID management. He works as a respiratory physician in Siddhi Hospital at Nasik. Yes, Dr. Swapnil, welcome to the forum. It's over to you, Dr. Swapnil.
Am I audible?
Yes, you're audible.
Yes, sir.
Thank you all the eMAPCON team for giving me opportunity to speak on role of ECMO COVID in COVID-19. As we see, the COVID-19 declared pandemic on 11 March 2020, there was a significant increase in the hospital as well as ICU admissions globally. And invasive ventilation rates were around 30 to 71%. A small proportion of these patients did not respond to the conventional therapies of the ventilator strategies, and which may require ECMO. As the pandemic has evolved, there has been steady increase in the ECMO cases. The provision of ECMO may be challenging from both resource and ethical point of view. What is ECMO? ECMO is a modified form of cardiopulmonary bypass utilized in the management of severe ARDS or cardiac diseases. Mainly in COVID-19, we apply VV ECMO. It provides a prolonged cardiac and lung support. It allows support till disease resolves or reverses. But underlying cause has to be reversible and treatable. So generally, if you see the ECMO circuit, VV ECMO is applied in ECMO in COVID-19 cases where ECMO circuit is in series with the patient, where the blood is withdrawn from the femoral vein, so-called, if the double lumen is used, is rotated through the pump, is given to the oxygenator where the O2 is loaded and CO2 is removed and blood is again returned back to the body. So in that case, if you see the guidelines, the ELSO guidelines where the total cases registered of ECMO for COVID-19 were 2,966. But in last 90 days, around 2,200 cases have been put on ECMO in COVID-19 cases. The main concern is the mortality, which is around 42%. North America being the highest number to put the patient on ECMO in COVID-19. As far as Indian experience goes, around 80 patients have been put on ECMO from 24 centers across India. The average age which is to be put on ECMO are 29 to 70 years. The commonest indications were ARDS, ARDS with cytokine storm, ARDS with sepsis, pneumothorax, pneumomediastinum. After giving the initial therapy like high flow nasal oxygen, awake proning, or NIV, or invasive mechanical ventilation, there became a role of ECMO. It was initiated as early as 3 hours after presentation to the 15 days on ventilator. The complications, common complications were thrombosis, sepsis, multi-organ dysfunctions, and outcome again depends upon the institutes, is around 25 to 45%. Total duration of stay is around 20 to 40 days of ICU. So while we are planning for ECMO in COVID-19 patient, we have to have all the factors kept in mind. First is resources. We should have a multidisciplinary team of experienced professionals of training in ECMO in initiation, maintenance, and discontinuation of ECMO in critically ill patients. We should have a competent planning, resource allocation, and infection control program in hand. Use of ECMO in a even limited number of cases may overwhelm the institution burden. So preparation, it requires a team approach, team support, a senior physician, ECMO physician, surgeon, intensivist, anesthesiologist, along with nurses, physiotherapist, and perfusionist. All should be worked there for 24/7 to take care of the patient. All members should have education regarding appropriate use of PPE. As you all know, COVID-19 is a thrombotic disease. ECMO circuit is applied, but one circuit also has to be kept standby because being a COVID-19 thrombotic disease, there may be chance of blockage of the circuit or oxygenated because of the clotting. Planning for decontamination of the ECMO equipment is also necessary. There are too many cases where they have been managed at a secondary level hospital or taluka place hospital. So we should have to have ECMO support, preferably in a single care unit where space can be utilized for the other critically ill patients who require ventilatory care. That reduces the exposure of infection to the healthcare personnel. Support system, like if we want to take a transport the patient from one hospital to the another, the appropriate and safe transfer should be there. Management of resource intensive care daily for patients receiving ECMO. So what is different in ECMO in COVID? There are multiple issues like management issue, resource restraints, referral restraints, and political restraints. We'll go one by one. So management issues, where too many cases are there which are eligible to put a patient on ECMO, but judicious patient selection has to be there. Younger patients has to be given a priority. So reserving ECMO only for those cases who are most likely to get benefited out of ECMO. We should assume the acceptable level of care can be maintained for other patients also, because they also need proper care. Withdrawal of ECMO from those in whom there is no perceived chance of meaningful recovery. Before patient putting on ECMO, we have to assess them by a RESP score, including all multiple parameters, including age, immunosuppression, acute respiratory diagnosis with other comorbidities like CNS dysfunction, neuromuscular blockade, other infections, inotropics before ECMO. So if all parameters, ECMO to be initiated at a lower risk class. So to have good outcome. A referral distance, initially as the patient is admitted in ICU with not all the facilities of ventilator and all, so ECMO was not given option to such cases at an early stage. As we all know, initially cases were managed at all government hospitals where a number of ECMO machines are less, so ECMO option was not given to those in those times. There was high workload, limited manpower, poor outcome, and fever was the main concern for restraint. Even lack of ICU staff, lack of ICU space, and non-shiftable patients were contributing to the referral restraints. Initially, we were not prepared to work 24/7 to fight against this pandemic. So in the resource restraint, assistant availability and their willingness to work 24/7 was the issue. Perfusionist and staff allocation was the major concern. Blood and blood product availability and disposable and circuit issues. In the initial time, there was capping in a billing, so we were not promoting or giving them an option for ECMO in the initial cases. There were restrictions to transport the patient or interstate transport or interdistrict transport, so ECMO was not used in the initial days, and there was lack of air ambulance services to put the patient or transport the patient. Also, has given a clear-cut guidelines. It all depends upon the capacity of the institute. Like they have divided into the 4 class, where the conventional capacity, like what we are doing the ECMO in the previous days, where the capacity of the institute exceeds. So in that, we can offer VA ECMO to COVID and non-COVID patients. In contingency capacity tier 1, where the system is running within the expanded capacity, where tries to maximize the resource benefit ratio, VV or VA ECMO both to be given option with younger patients with single organ failure, and judicious use of ECMO to non-COVID indications. As we go beyond a contingency capacity tier 2, where the capacity is close to saturation, where only we have to prioritize the ECMO patients and prioritize the non-COVID indications with better chance of survival. In that, VV ECMO option is given to the younger patient with single organ damage. Option for VA ECMO was not given. And where the capacity of the institute is overrun, ECMO is not feasible to both, even COVID-19 and non-COVID-19 patients. There are certain absolute contraindications to put a patient on ECMO, like advanced age, clinical frailty scale more than 3, mechanical ventilation with the comorbidities more than 10 days, like CKD, cirrhosis, disseminated malignancy, advanced lung disease, severe acute neurological disease, contraindication to the anticoagulation, and ongoing CPR. Among the relative contraindications, obesity more than BMI more than 40, immunocompromised states where the chance of outcome from the ECMO is poor, no legal medical decision maker available, and high dose inotrope requirement. So what is the patient selection criteria and timing of ECMO initiation? As we all know, where the severe ARDS cases where PO2 FiO2 is less than 150, even after giving a proper the conventional care like prone positioning, neuromuscular blockade, or appropriate PEEP, if the PO2 FiO2 ratio is less than 60 for more than 6 hours, PO2 FiO2 ratio less than 50 for more than 3 hours, or hypercarbia, even if PO2 FiO2 ratio more than 150, we should look for any contraindication for ECMO. If it is not there, then patient is a patient to be selected for appropriate ECMO use. What all care to be kept in mind once we put patient on ECMO? As we all know, COVID-19 is a thrombotic disease. So if we see the article, COVID-19 associated coagulopathy shares the similarity with the classic DIC. One paper has been published where a coagulation profile of 183 hospitalized patients revealed that medial onset of DIC is at 4 age or the 70% of the people. There is an imbalance between the procoagulant and anticoagulant factor in COVID-19. So once the patient is put on ECMO, we have to target a higher ACT values around 180 to 200 seconds. That we target generally 140 to 160 seconds in normal patients. We have to target higher anticoagulation in such patients. There is chance of circuit thrombosis if we reduce the ECMO flow. We have observed both thrombocytopenia as well as thrombosis in COVID-19 patients. Other parameters to be looked for respiratory, like once we patient put on VV ECMO, gradually FiO2 has been reduced to around 50%, with PEEP of 10 to 15. Early enteral nutrition has to be started with a proper precautions when dealing with the body fluids. Mobilization with on ECMO is not possible because chance of proning and the disconnection of the cannula is there once the patient is on ECMO. So we should properly handle the patient once the patient is on ECMO. ECMO monitoring, like daily we have to monitor the cannula size, cannula position in term by doing a echo. We have to check for the X-rays to improvement for the daily improvement. ECMO monitoring in terms of pre-membrane and post-membrane ABGs. We have to check for a circuit blockade or circuit clotting. So judiciously use of the blood products is also advised once the patient is on ECMO. Other parameters like complications what are dealt with the COVID-19 patients, there is a high chance of bleeding from the cannula sites, neurological injury either from hypoxemia or thrombosis, thrombocytopenia, either heparin induced or other causes like DIC or shock liver. Cannula related vascular complications are common.
So 5 minutes left.
Yes, sir. So how do you decide about winning from ECMO? Once there is improvement in the ABG parameters or X-rays improving, we can think of winning. Once we start thinking of winning, initially we have to reduce the ECMO blood flow rate gradually. We should wait for 6 to 12 hours. If the ABG parameters are fulfilling, definitely we can reduce the ECMO sweep rate. And if the both parameters are settled for 24 to 48 hours, we can look for hemodynamical stability of the patient. There should be improvement in the X-ray as well as ABG improvement should be there with PO2 more than 150. If SCT value is more than 35, we can plan for discontinuation of the ECMO. Generally, average days of ECMO required in COVID-19 is around 14 to 20 days. Decannulation. A full PP precautions should be observed while decannulation. Adequate care should be taken to prevent contact with the body fluids. Careful assessment of bleeding and thrombotic risk is recommended before decannulation. Venous cannulae can be removed at the bedside and bleeding can be controlled with topical pressure or sutures. All the team members should have appropriate PPE in hand before planning for decannulation. We should minimize the aerosol generating procedures to prevent the infection. So take-home messages from my talk will be ECMO is still underutilized in COVID-19 patient because of certain restraints. Timing play an important factor. If applied in the initial period, it provides a favorable outcome. Scarcity of staff, manpower, healthcare personnel is the main issue. And being a thrombotic disease, complication rates are higher in COVID-19 patients. Thank you. This is our ECMO team.
Yeah, I must say nice job, Dr. Swapnil. Because of short of time, we won't be able to take any further questions for this session. It was a nice talk. Thank you so much. And thank you, eMAPCON, for having this session on ECMO, which is relatively a lesser used modality, as Dr. Swapnil has said. Over to you, Dr.
Thank you,
Amit.
Rishikesh.
Yeah.
Thank you, Swapnil. I would ask Bhavik to proceed forward, please.
Sure, sir. So for the next talk, we have Dr. Hari Shetty. He's going to be talking about Physicians Heal Thyself. It's the theme of our e-conference. I would like to call upon Dr. Bhaimangesh Naik. He's a senior physician from Bedapur, Navi Mumbai, associate professor attached with MGM Medical College, Navi Mumbai. He's a regional member of MAP Konkan region and joint organizing secretary of MAPCON 2019. On to you, Bhaimangesh, sir.
Thank you, Bhavik. Happy Dashara to everyone. I remember Hari Shetty sir had his talk in MAPCON 2019 at similar time and it was delayed. We are delayed by almost half an hour today. Can I get his slide?
Yeah, sure.
Yeah. Hari Shetty sir is HOD Department of Psychiatry, Sion Hospital. He is topmost leading psychiatrist of Mumbai. I must have seen him on television regarding current incidents about Bollywood superstar, one of the person. He conducts very popular and successful YouTube channel along with Dr. Shashank Joshi sir. Over to you, Hari Shetty sir.
Bhai Mangesh Nayak, thank you for introducing me. You look much handsomer live than you look in the picture, but I'm not the head of the Department of Sion Hospital. That's my friend, Dr. Shah. I'm the head of my own department, which is
head of the unit.
No, not at all. I'm not in a medical college. I work at Dr. Hirandani Hospital as a consultant, and I actually practice psychiatry. Thank you. In any case, you look smiling. You look very cheerful. You look much more cheerful than all the psychiatrists in Bombay. So, thank you. Thank you everybody for inviting.
Sorry.
No worry, sir. Thank you everybody for inviting me, Amit, Girish, and all the office bearers from APICON. Let me start by saying that healing thyself starts from believing that the IMA will one day send your picture on WhatsApp that we are sorry to announce that you have passed away. And that is the real truth about life. IMA and other organizations will send this picture. And this picture is not only the pictures who have passed away now, but we also are going to die one day. And that, I think, is one of the most important truism and reality. If we really gather this in our mind, what happens is anxiety goes down, behavior improves. And as behavior improves, life gets healed automatically. Now, why I'm saying this, why I'm striking a so-called negative note, and it's not negative, it's positive, because whenever we attend funerals, we get into an existential mode for one night, and next day we are the same. But during Corona times, our existential thinking has really changed, and we have started dwelling about lives, relationships, quality of life, how we'll treat our patients, how we'll treat our close relatives, will we withdraw our cases against our family members in the courts about property. So the existential questioning is one of the most important roads to heal yourself. I still remember taking sessions in a very premier municipal hospital on the invitation of the dean with Arun Bal, long ago, Dr. Arun Bal. And there was one question which was asked by an orthopedic surgeon when I said that, is it right to smile at your patient in spite of pain? And the orthopedic surgeon put his hand up and said, he will get very upset and angry because smile would mean you're trivializing his pain or you're not grieving with him with his pain. I said, my dear doctor, if a close relative of yours comes home with an orthopedic problem and he wants to get hospitalized under you, when you open the door, will you look at him with shock? Will you look at him with anxiety, or will you look at him with a face which is healing? He said, of course I'll smile. So that's it. Healing is not one-sided. Healing is bi-directional. So when you smile at a patient out of concern, he smiles at you back, even if he has not improved. You are also healed. It's not that you are healing the patient's always healed. And then you'll ask me a question, are we robots? Is it possible for us to do it all the time? No, it's not possible for us to do it all the time because we are not artificial robots, but as much as we can, if there's a compassionate view about a patient, the patient looks at you with compassion and your energy improves. It's not only the gratitude, but the smile also that works. Across my practice, what I have learned, and I've made a lot of mistakes, a million mistakes. Across my practice, what I've learned is healing thyself is to get some amount of rhythm between your mind and your body. I used to laugh at yoga and vipassana 30 years ago. No, we were bred in English schools. We were bred with Guyton, Gray's Anatomy, and of course so many other books. And our teachers never talked about synchrony between the mind and the body. In psychiatry also, we were taught about neurotransmitters, the medications, illness and therapy. But very rarely we were addressed with issues of life and issues of mind for somebody who's normal. And I discovered across time, thanks to Dr. N.S. Vaya, late Dr. N.S. Vaya, that that yoga opens the prana, brings down the fear, according to Vedanta. But according to the Americans, it improves your hippocampus, your memory, it resets your mind for you to be in an orchestra between mind and body. It calms down your amygdaloid so that your reflex anger really goes down, the fatcal behavior goes down, the movement behavior goes down, and it improves the prefrontal cortex where the decision-making process improves. It's high time we explore this across our practice, not when we are 50, but actually in medical schools and in schools. If I say that when I visit a school every week, my dear friends, across the last 25 years, even now, and those schools which have compulsory meditation and yoga, the 10th standard kids are much calmer, much well behaved. The children in Jharkhand, in the tribal schools, are much calmer because the nature heals them, because they're in touch with the trees, the grass, and the mountains very naturally. So healing their self would mean going back to the basics, going back to nature, and practice any form of meditation. The third thing which I felt is very important for us, I have learned it through my mistakes. Remember that I'm not a wise man. And that is, in your work, your patients will find another doctor if you are not available. But your family will not find another husband, another father, another brother. So how long will you run? How much will you run? How many attachments you'll have? And how many hospitals you would want to operate? And this is an education which we were not taught when we were doing psychiatry or medicine. And this is something which I realized a little late, but not very late. Not very late. So your patients will find another surgeon, another psychiatrist, but your children will not find another father. So if you are able to not go back home as Hercules, who feels that the entire world is on his shoulders and you're doing so much for your family, no, not at all. You're not doing so much for your family. Your spouse does much more, even if she's employed or even if she's working. The maximum work in our country is done by mothers, teachers, and constables. So it is so important for us to really understand that family also comes as much as our work. And it's so important to also understand that appreciating the invisible contribution of all the spouses, men or women, in building up the family really helps you to heal well. And that is something which we need to learn much earlier than much later. I will not say sleep early, sleep on time, all those things are there on the net, but I think getting mind and body in rhythm, this third thing, is appreciation of abundant appreciation, the people who contributed to your growth, who contributed to your practice, who contributed to your life, also opens your heart, opens your mind, and you really get healed. The next thing which I feel is important based on my experience of my life is managing your failures. You know what? When a psychiatrist leaves a patient, he is depressed across time. You will not understand how we feel when a patient commits suicide. It's one of the most difficult times of our life. The most difficult times of our life. And it's very true for a physician, for a surgeon, for anybody in medical practice. And I was told by a doctor that when you work in fields like surgery, oncology, ICU, you need to numb yourself so that you block the emotions associated with how you feel about the death of a patient, how you feel about a loss of a patient, how you feel about anger of a patient towards you, because you may have probably diagnosed something wrong, because none of us can diagnose every illness correctly all the time. And what happens? If you numb yourself, what happens is all those emotions which were there gets repressed and blocked. You slowly become dehumanized. You have a hard exterior. You may be an efficient doctor. You'll have a hard exterior. And what happens to us is exactly what happens to encounter specialists. They are not able to love. They're not able to feel. They're not able to listen. What happens to us is exactly what happens to morgue attendants who become dehumanized. So let us save ourselves from dehumanization. When there's a bad day, there's a death, what is very important is not only to talk to your spouse, maybe spouse will listen, but sit down as a team, as team from across. Your competition, not with your competitors, so-called competitors, but there's no competition at all on the earth, and share and say, this is how I feel. This is I never knew that this could happen. How did I do this? It was shouting at me that it's malaria, but I missed it, and I feel so sad that this happened. And if there is a debriefing which happens automatically with your colleagues whom you love, who don't really judge you, you're automatically healed when you have such a disaster, which is very common in our practice, which is not very uncommon in practice. And secondly, when such a disaster happens, it's so important to face the family. And when they ask you a lot of questions, so important to face the family. Sometimes it can become very rough and hostile. But what is very important is to face the family, not only when you succeed, but also face the family when you lose. And that also helps you heal. Having said that, I would like to ponder on 2 or 3 points, which again is very important. Well, all of us have been through medical college, and we have our colleagues in different places in practice. Some of you may have got medals, some of you may not have got medals. And sometimes the economic achievements may not be the same. Economic achievement may be very different, and that does not actually matter. So if you nourish your friendships across time, from the time you were in a hostel drinking together, from the time in your hostel when you boozed and puked in each other's bed, from the time of the hostel when we were preparing for the exams together, and if you continue that friendship in spite of differential achievements, probably in fame and probably in money, you will understand that friendships heal, where you can be absolutely nude. So in spite of you having a spouse or family, you need a safe space where you can be emotionally nude. And let me share and confess that I talk to my friends. Hi Nilima, how are you? I talk to my friends twice a week, Sunday, Wednesday, and I use all the languages. And you know what? I use Oxford Marathi, Oxford English, and I can be just emotionally moved. And that is also a place of healing which helps us to a great extent. Last two concepts which I'm going to share, I'm going to stop after these two concepts, and that is research across the world has shown that if you heal your mind, you save your body. And as of now, in the corona angst period, there's a lot of anxiety across time, Practicing is so difficult, going to a clinic is so difficult, and we have lost a lot of our friends and our colleagues. And anxiety will bring down your immunity. Anxiety will really cause a lot of issues across your body. So as I slowly close, I would like to remind you that apart from yoga, come what may, exercise is a healer, and that is something you should be doing across time inside your house or others. As I slowly close, because I would like to have 1 or 2 questions and any observations, is that this is researched, and that is Harvard has shown that if you are shown a movie of kindness, immunoglobulins improve. Harvard has shown that to get your hypothalamo-pituitary adrenal system intact, Kindness also opens your heart and resets your brain. So I would close my presentation of 15 minutes in 12 minutes by saying that as doctors, as we run around and we become dehumanized across time, what is very important is to get back the grandmother's glow in our own face, those innocent grandparents, uneducated, गाँव वाले, उनका चेहरे में इतना innocence, इतना transparence था. Let us get it back by probably being kind to our worst enemy, by probably being kind to our worst competitor, by probably being kind to somebody across our family who has really stopped us in our life. With this, I stop. I would just stop by saying, heal your mind and save your body. Thank you.
Thank you, sir. Are there any questions, Bhavik?
I have to make a comment, Dr. Haresh Shetty. I think you are the only speaker with certain unique points in the two-day conference. One, you are the only speaker without a PowerPoint. Not that you need one. I'm sure you yourself, it's a pleasure just to see you as a slide. So when we just listen to you, see your face, that speaks volumes, and that we don't require any more PPT beyond that. Secondly, sir, you are the only speaker who really adhered to the theme of the conference, Physician Heal Thyself. So what message you've given us today at the last session of the day, I think was really a healer. We all need to have heard this, need to have implement this in the time to come. So I just wanted to thank you so much. I would want to specially thank sir because I know he's rushed out of his YouTube program and he must have probably just switched two screens, one here and one there. And I know you're a very busy person, sir. I thank you so much for having graced our platform this afternoon and having given your words of wisdom and guidance to us. Thank you so much.
Amit, can I add one thing to your thing?
Sure, sir.
He doesn't require PowerPoint. His every point is extremely powerful
for
all the physicians to follow.
Perfect, sir. Perfect. Absolutely perfect.
Thank you, Sriran Gokhale, who's probably my NIRAT, a little senior to me, if I'm right. If I'm right. And thank you, Amit, for those kind words.
Thank you, sir. Right. So
Thank you, sir, for adhering to the time also. And I hand it over to the organizers.
Right. Thank you, Bhai. Thank you, Shetty, sir. So at the last, I have been just given the small little task now of sort of winding it all down because last 2 days, we've all as MAP committee, senior EC members, MAP faculty, our presidents, our past president, our treasurer, joint secretaries and treasurers, everybody here has played a penultimate role in getting the entire eMAPCON together. I can't start and finish the list, but I'll make an attempt to form conceptualizing the idea, Dr. Devgakar, from supporting the idea, Dr. Mahavarkar, from guiding and driving the idea, Dr. Rajadaksha, from completely and able support to the entire concept, Dr. Anjali Rajadaksha, for advices on every step of the way, Dr. Gokhale, Dr. Pingre, Dr. Rajesh Patil, Dr. SV, and to say the least, every senior member of MAP here have made this possible. I, from the bottom of my heart as the Secretary General of MAP, would want to thank all of you for having this eMAPCON put together. Second, the entire thanks to the galaxy of speakers. Believe me, if I have been able to get all the faculty speakers in a matter of 3 to 4 hours, it was because of the banner of MAP that I called them from. So it was two or 3 weeks ago on a Sunday afternoon, I was calling up everybody, and everybody, the moment the phone call is from MAP and the Secretariat of MAPCON, immediately agreed. So I think that's what we've reached. So thank you so much to our faculty of speakers who've made this entire conference a grand success. Third is the delegates. I think we crossed 2,300 plus. I specifically would again mention and specifically would want to thank Jagdish from Sipla. He could get in 32 registrations from African countries who are wanting to attend our eMAPCON. And that, again, thanks to Dr. N.K. Singh, because we went on the national cmesofindia.com. So at a national level, our sort of reach was much more bigger. at an international level, we could attract some delegates also. To thank to all the delegates for having logged in. And I would want to tell that everybody would be sent in certificates the moment this session is over, including the faculty and the delegates. And lastly, a special note of appreciation and a heartfelt thank to the entire event management team, specifically for Sohail, for having entertained my numerous phone calls and having been very patient with me. Specifically for Bhavik, I think he's learned a lot of medicine in the last 2 days here, having pronounced every word of medicine in the title of the speakers accurately, by not making any mistakes in the pronunciation, by being respectful, by keeping the time. He was a one-man show at the back end. He compared, he kept the time, he politely told the speakers about the end of the time. So thank you so much, Bhavik, for your support. Ahmed was instrumental in keeping the SMSs going to all the delegates about registration confirmation. And he also helped a lot of senior faculties in their presentations and how to use the Zoom platform. So I would thank all of them. And lastly, everybody here, this entire robust audience who's here with this afternoon, Dr. Gokhale, Dr. Yagokar, Dr. Irish Patil, Dr. Girish Rajadaksha, Bhai Mangesh, SV sir, everybody who's here, Dr. Kedkar Madam, Kondapale, Dr. Vaishali Lokhande, Rudrakshi sir, everybody, Dr. Mukund Penurkar, our next Pune people, Dr. Mahavarkar, he's been the strongest support when it comes to MAP and MAPCON. So thank you everybody for a wonderful session. And on the behalf of eMAPCON, thank you once again. Be safe, be sound, be happy and healthy. And I hope we can all meet each other in Pune next year for the MAPCON 2021.
Amit.
Anybody would want to say anything?
Yeah, I want to say.
Yes, sir.
PK, you're gone.
Yes, Maharka, sir.
PK, unmute yourself. Yes.
Okay. Now, you talked about all the people. I am also very much thankful to you. But some companies, they have supported us, and they have made us very easy and economically viable map. And this program really was actually the low profile in economics. That means we could do this program successfully more than MAPCON with a minimum budget, and we got companies which will help to generate our funds. For them, we are very much thankful. I am thankful to MAP President and the Secretary of this conference. This is Organizing Secretary, Dr. Degaokar, who is our mentor of this eMAPCON, we can say. He is looking very smart today.
Always looks very smart.
Entire
specifically today, I mean.
Yeah, all this
Thank
you. And Sohail has supported us. So thankful all of these people, including our core committee and committee members. Yesterday I could not see Sriram Gokhale. Today I am saying that I am very happy to see Sriram Gokhale today. Bhai Mangesh, SP Kulkarni, Rajesh Patil, all the persons. Today I am not able to see our MAP President Pingle. He was there the whole day yesterday. So PK Joshi, thank you very much, and each and everyone who attended or who did not attend it. But from bottom of my heart, I am thankful to each and everyone. Thank you very much.
Amit, I will say only one word. It was a great show.
Yes.
Finish.
Thank you, sir. Thank you so much.
Amazing,
Yes.
Amit, amazing present. Very good conference,
Yes.
Good academic feast.
Thanks to all of us. Thanks, not at all. Thanks to all of us. Sir, thanks to all of us. Rajadaksha sir, all closing comments from you, please.
Yes.
Amit, you have set a landmark, new landmark.
Amit has summed up very nicely. And I would like to thank all the galaxies of speakers, all the pharma companies who have supported us by giving unconditional educational grant toward this eMAPCON, large number of delegates who have registered, and of course, large but not the least, the speakers, all were the stalwarts, but they restricted to their time and they delivered fantastic lectures. I'm getting feedback from so many delegates who attended the sessions, and they're saying it was wonderful. Each and every lecture was wonderful. That is what the feedback which we all are receiving. So I think the one man which was, who has worked very hard, is Dr. Amit Saraf.
Yes.
Of course, he was supported very ably by Dr. Mahavarkar and Dr. Devgaonkar. Because of my own commitments, I couldn't contribute much. I must accept this, though my name is there as organizing secretary. But I think the credit should go to Trimurti, and mainly it is Amit Saraf and the team. You know, others also supported obviously, but these three people are the main who are responsible for the grand success of this eMAPCON. And I'm sure we can hold many more till the time COVID is going on, because of the response that is very, very encouraging. So again, I would like to thank each and every person who has contributed to the success of eMAPCON. Thank you.
Thank you, sir. Thank you,
This is a banner or a map which has helped us, sir. Thank you.
Sir, we hope we can get the actual conference next year. We are, from Pune team, we are very much thankful for this particular conference. This was otherwise being cancelled or postponed to next year. Dr. Devgaonkar had an idea of continuing with the MAPCON, and this was very nicely done by Dr. Amit Saraf and the whole team of Dr. Mahavarkar, Rajadhyaksha sir, and Narayan Devgaonkar sir. And we as last time also said, the MAPCON has raised its standard, and we'll have to live up to the this particular standards of MAPCON. Thank you very much.
Mukund, thank you. Incidentally, Mukund, the dates of Pune were the same as the eMAPCON. So I think even you were planning 24th, 25th of October in Pune. So we did eMAPCON on the same dates.
2nd August, no?
2nd October it was.
2nd October it was.
2nd
to 4th October.
November or October?
October.
So have you, Mukund, have you decided about next year's dates? Tentative.
Corona will decide.
But sir, just Shashank told us, no, he is likely to conduct EPICON. Even if it is virtual, but he will be calling some people across the state.
I am in Mumbai.
In Mumbai itself.
Sir, they फक्त faculty ला बोलवणार आहे. It will be a physical conference for the faculty only,
200 people
not the delegates.
That is the beginning, na? But that will be a beginning for get-togethers.
In February, IMA Mumbai is conducting in Trident Hotel with 200 delegates physically present and other delegates virtually. 200 are allowed. 200 are allowed in February.
Oh, great.
I think Mukund पुण्यापर्यंत will be okay.
म्हणजे सुरू व्हायला लागलं भाऊ आता काय असं बँक अमित काय व्हॉट इज दिस अरे अमित सॅटर्डे गेला सॅटर्डेला बँकवेट नाही
देगावकर सरांनी मला काल मेसेज केला बँकला जायचं का म्हटलं चला आपापल्या घरी जाऊ
अरे सॅटर्डे इज ऑलवेज बँकवेट आहे यार असं
प्रत्येकाने आपला बार आपली ब्रँडी आणि आपला बँकवेट असं होतं तिथे
बार बार देखो
बार बार देखो आपला बार देखो